Who's joining. Good morning, everybody. Good morning for at least where I am. There are thankfully people from all time zones at the moment. So good afternoon to those on the eastern part of the time zone, and very good morning to the ones to the more western part of the time zones. Thank you all for joining us today. We are really looking forward to a brilliant meeting. We've done this. We've did the first one, the first version of this 2 years ago, and it was really welcomed by everyone with a lot of attendees. My name is Evangelos Drossos. I'm a neurosurgeon from Greece that's currently working in the UK, and I'm a member of the EANS Young Neurosurgeons Committee. With me organizing this is Saki Bajadoun from neurosurgeon from the UK. We're both working in the UK, and we're both in the EANS Young Neurosurgeons Committee. And we've done this version of the meeting this year with the CNS Trainee Committee, and the Malesa it was the point of contact for us with that group. I don't want to delay more with my part. We will start with Professor Sala, who is the president of the EANS, who will give us his greetings, and he will talk to us about EANS and the opportunities that one can find in there. Professor Sala, the floor is yours.
Thank you, Evangelos, and thank you also to Sakiba and Milan and the Young Neurosurgeon Committee for giving me the opportunity to join all of you today. I have to say that I'm particularly pleased because this webinar is very much fitting with the vision of the EANS, which is to provide education not only within Europe, but also in collaboration beyond the borders of Europe, and therefore this liaison with the training committee of the CNS, I think, is particularly valuable. Let me try to share my slides. Okay. Can you see it?
Yes, we can see.
Okay, very good. So what I would like to do in this 12-15 minutes, basically to share with you our vision, and I would start from the motto that we have embraced for the next 2 years, I care, but we'd like to focus mainly on education and research, which are certainly some of our cornerstones. And I would start from the mission of the EANS, which is to enhance the quality of neurosurgical patient care through training, education, and research. So this is why we are here for. And the motto that we have embraced for the next 2 years, I care, reflects not only the idea of serving this society in many different capacities, but is also an acronym which stands for 5 keywords. I is for inclusivity, C is for consolidation, A is for alliance, R is for research, and E is for education. So obviously this is very strongly related to our mission, and we'll touch base on some of these, particularly with regards to research and education, because I think they are probably the most relevant to our younger colleagues. But I will certainly say a couple of words about inclusivity. As you may imagine, Europe is really, there is a huge diversity within our continent in terms of history, traditions, languages, culture, neurosurgical expertise. But certainly this variety and diversity represent an opportunity and a strength for us, not a weakness. And therefore, we really would like all our national societies affiliated to the EANS and our members. So we are now reaching more than 3,000 members, which are constant growth over the last several years. Not only to be, but to feel included in our community by being actively involved on our many activities and also interacting one to the other. So inclusivity for us is certainly very important. I will briefly touch base also on alliance. because I think this is very much pertinent to the spirit also of this webinar. Alliance means that we certainly need to build bridges within our EANS community, within Europe, but also to look beyond the borders of Europe. And that's why we are very keen to strengthen the liaison with all the other continental societies, the Asian, African, Latin America. We have a well-established link and collaboration with the WNS, but this webinar is very timely because recently we also started to strengthen the liaison with the CNS. Myself and a few other colleagues from the ENS will represent the ENS at the CNS meeting in Washington. We already spoke with the CNS president, Martina Stipler. So I think that this joint venture also with the CNS training committee is very much fitting with the spirit. And of course, we are linked also to we should collaborate also with our supracontinental neurosurgical society. Now, research and education as of paramount importance for neurosurgical training and advancement in the field. Within the ENS, we have a research committee and a research fund. Catherine Rabier is the chair of the research committee. Their mission is to organize courses on research methodology, to judge on the research awards which are offered by the ENS, to encourage collaboration, multi-center collaboration. And Catherine is also our ambassador to the European Brain Council, which is an important organization based in Brussels. Very close to the European Union headquarters. And that's an important place where to be to advocate for neurosurgery. We had a very nice joint webinar with WNS a few weeks ago, addressing specifically the issue of funding research in Europe as compared to North America. It's quite different the way we address that. That's why also to have communication with colleagues overseas, it's valuable to understand different ways that we can take different pathways to support research within neurosurgery. We also have the so-called ENS Research Fund. This is something that we established some time ago to support young neurosurgeons aiming to a career also in research with a small seeding grant of 10,000 euros to support their pilot or proof of concept study and eventually make them able to compete and apply for the most competitive European grants like the Horizon grant. So this is a very nice project which started back in 2018. The thing is that when we look back at where we awarded our research fund, the awardees were for the vast majority, 70% of them, were from only 4 countries, Germany, Switzerland, Italy, and UK. So on one hand, we were certainly awarding excellence. These were the best projects evaluated by all the committees. But on the other hand, we were missing inclusivity here because only 2 out of 44 grants went to Central and Eastern Europe. And so therefore, we decided to very recently open a new track for the research fund, which is the so-called Widera track. And this is really embracing a new call of the European community, the European Union, which is the Widera program, aiming to widen the participation and spreading excellence across Europe. So this program targets young neurosurgeons who aim at a research career despite the lack of opportunities in their country of resident training. And the idea behind is really to support them to build research and innovation capacities in countries with limited resources in order to really have the potential for transnational research and innovation all across Europe, involving also the countries which have limited opportunities from this standpoint. So any trainees who is doing his training in the country listed in the Widera program has the possibility to apply to the Research Fund Award that we just launched a few months ago. So the EANS is going to support up to 4 grants of 15,000 euros to allow these trainees to spend a 6-month research visit in an experienced and well-funded center within Europe, and then possibly go back to their country and institution and continue the research there and support the development of new research projects. And finally, education has always been probably the main pillar of the EANS. We have been offering both post and pre-graduation courses. You can imagine how challenging it is to have a homogeneous training curriculum all across Europe. That will be probably very difficult to achieve, but certainly the EANS has always promoted and worked very hard to offer education all across the different countries which are part of our community. So the pre-specialist qualification training is represented by our traditional EANS training courses, which were established in 1974, so many years ago. In 2012, we introduced also the hands-on courses. And then there are a number of postgraduate training courses which are open, of course, to all the trainees and also to those who have already started their career as young attending neurosurgeons. The traditional training courses are based on a 4-year cycle. Every year we address one of the main topics within neurosurgery, tumor, vascular, head injury, function, and peripheral and spine. So we offer 3 courses every year. In a 4-year time, every trainee will complete all the training courses. What they should expect when they attend our training course, of course, we have lectures by experts on the state of the art of different areas within neurosurgery. We have the breakout session where we disentangle specific neurosurgical scenarios with a live discussion, interaction between the trainees, and also with an expert who will provide the view on the topic. And then we have the How I Do It mainly video session, again by the masters. And then the very popular discussion group where 20-25 trainees interact with a couple of faculty to discuss clinical cases in a very interactive manner. So at the training course, certainly we work very hard, but we also have good times. Every evening there are social events where both the trainees and the faculty are actively involved. These are unique opportunities to establish friendship, collaborations among with the other peers, but also between trainees and faculties. These are unique opportunities for creating mentorship. So I think really the training courses represent one of the best opportunity that we offer to our trainees at the EANS. These are, for example, the 3 courses that we have organized this year. The first one was in Sofia, Bulgaria. Then we have one in Norway, in Stavanger. And we'll have the third one in Latvia and Riga at the end of August. The EANS offers a board exam in neurological surgery. This was updated in 2015, also in collaboration with the section of neurosurgery of the European Union of Medical Specialists. The exam consists in 2 parts. Part 1 is an electronic multiple choice questionnaire. Part 2 is an oral examination. And since the meeting in Sofia, all those who graduate from the exam they can enjoy their graduation ceremony at our annual Congress. And I think this is also a very nice moment within our Congress to give visibility and celebrate the new graduates from the board exam. Going towards the end, I would like to mention the EANS Young Neurosurgeon, the Young Neurosurgeons Committee, which is the one which has organized this great webinar today. So the responsibility of the Young Neurosurgeon Committee is basically to support young neurosurgeon at the end of their training and towards their first few years as young neurosurgeons, so when they start to establish themselves professionally in the field, to support them to develop their leadership, research, communication, neurosurgical skills. Milan Lipic is the chair of the committee. They just had their meeting in Faro, which was very successful last May. And this is just really a bridging committee between the years of your training and the years when you're establishing yourself as a more experienced neurosurgeon. So it's extremely valuable for the EANS. And I'm very glad that now we have also this building collaboration with our counterpart in the CNS. And I will just finish mentioning a program that we are now launching is the so-called Junior ENS or GENS project. Basically, the idea is to update, strengthen, and develop an existing database that we created years ago, but was not much implemented, not very popular yet. So basically, the idea is to create this huge database where all neurosurgical institutions in Europe can post information about their opportunity to offer fellowships or observerships, both in the clinical and research setting. And we would like this database to be like the famous Denning treasure, robust, easy, affordable, and popular. So eventually, every trainee and mentor in Europe could take a look at the database and see what kind of observation fellowships are offered at the XYZ institution, which are the area of expertise of the center, if there is any possibility to support the visitors with housing or with some funding, if there is any medical credential for licensing in order to be able to be actively involved in the clinical activities, if there is any requirement for language. So ultimately, we hope this to become a sort of Erasmus program for neurosurgery to implement the exchange of our trainees across Europe. And why not in the future, this could also open to collaboration beyond the borders of Europe, for example, to establish twinning program with LMIC countries, but also for collaboration with the other continental society. So we'll stop here. And of course, I hope to see all of you and many more in Hamburg for our Congress. And please feel free to emailing me if you have any question. Thank you. And thanks again for the opportunity.
Thank you. Thank you very much for this very comprehensive presentation of all of the activities. And it's truly an exciting society to be part of. And it really gives a lot of opportunities for people, not only from around Europe. So you're all welcome to join us, become members, and join our activities. So thank you very much, Professor, for taking the time and for presenting us with this. And I will pass the microphone on to Milan Lepic, who is the chair of the EANS Young Neurosurgeons Committee. And without his support, this meeting would not be possible to give us to formally welcome everyone to this meeting. And then, Milan.
Thank you, Evangelist. Far from that it would not happen without me, and it would not happen without all of you. So, good morning, good day, everyone. I'm Milan Lepic. I'm current chair of this Young Neurosurgeons Committee within EANS, and we signed cooperation agreement last month with the CNS Residents Committee for organization of this June Expo, which is happening for the second time, and I was the part of the first one, and I'm also very happy that it's happening again. So, Young Neurosurgeons Committee is focused on young neurosurgeons, which is our main priority, but we are also focused on inclusion of trainees and medical students into the practice of neurosurgery through what Professor Sala mentioned as iCare acronym. So I would really like to thank from the bottom of my heart to the UK part of the Young Neurosurgeons Committee, who were actually making this beautiful thing happen. Mary Solo, to Sakiba Jadun, and of course to Evangelos for making this outstanding event happen. And really thank you once again. And I would really like to not spend any of your additional time for this. And I would like to continue by inviting Professor Claudius Tome to join us and talk about development of care in neurosurgery. Thank you very much.
Thank you so much, Milan, for the introduction. Sakiva, Evangelos, great initiative. Obviously, doing something together with the Americans is a very good idea. So I'm very happy about this. I'll try to share my screen. So basically, I was asked to talk a little bit about the possibilities and what you have to pay attention to when you pursue a career in neurosurgery. Obviously, for me, it's more a career that has an academic background. And obviously, I do have some disclosures which should not matter. Maybe my main disclosure is that I obviously belong to the Generation X. So my some beliefs are probably different than of the younger generations. And I will also not touch upon the different fields of neurosurgery. I will also not touch upon the new possibilities with AI, which will obviously influence our training and also our careers in the future. I think Emal is going to talk a little bit about that. But still, for most of you out there, your chairman or chairwoman that you will be faced with will potentially be Generation X people, at least at this point in time and for the next years to come. So maybe this is something that's important for you. And I would just like to give you some general advice and try to guide you through what you should think about. Obviously, some basic questions. Most important, what system do you want to work in? There are significant differences between North America, Europe, and not even talking about the less developed countries or the LMICs that we touch upon in the next part of this webinar. So this is very important that you think about what system are you working in, and then even more important, what's your personal goal? Do you want to be the boss? Do you want to make a good living? Or do you want to do research, change things? And this is really what's your main motivation, because you will only be successful if you are motivated to do your job and pursue this career. And how much are you willing to put in? It doesn't make much sense if you for whatever reason you don't want to put too much effort into your career. It may not be worth it to do that in the beginning, and you may really think about what's your goal that you want to achieve in 10, 15, 20 years. I'll talk very briefly about the medical system in Central Europe, Germany, Austria, Switzerland, and some neighboring countries as well. It's obviously different in North America and obviously very different in other parts of the world. So basically, we have socialized medicine. Everybody's insured. We actually have very good medical care, I would say, for everybody. Usually you cannot choose the treating physician or surgeon, so it's a very different system to other countries. But if you're privately insured, there's also a different way of dealing with that, and then you can choose your surgeon. So one of the problems that we have in Central Europe or in Europe overall, that in public hospitals you have low salaries, and in the private sector you have a competition for private patients, but then you have more opportunities to earn more money. Still, we have a very hierarchical structure. Different places in the UK, it's more consultant system. In Germany, it's more hierarchical. Chairmanship according to the old Humboldt's principles. And then the boss usually has full responsibility and liability in general, but also earns more. So in the past, this was a goal you wanted to go for if you were young. And this is changing now because also in private practice, you have different opportunities to have a good career. And so this structure is obviously challenged by the new generations. And I have the feeling that this will change in the years to come and hopefully not too far away. Historically, we were very monodisciplinary in Central Europe. And we had a big difference between academic and community hospitals, particularly in neurosurgery, because most community hospitals would not have neurosurgery. So how do we, as the leaders in the field or the chair people, how do we select people in academics and then potentially also for clinical practice? Obviously, we look at knowledge, grades, performances, previous performances, attitude, very, very important. Skills, of course, manual skills in our job, obviously are important, and all of that then adds up to the competency that we want to have when somebody pursues a career to make the next step in her or his life. So clinical competence, obviously surgical skills, subspecialization, you talk about it a little bit later on. Academic competence, do you have a research focus? How many publications do you have? Do you have grant money? That's the same in most of the academic centers. And then socioeconomic competence, management, business skills, also interpersonal skills. I have the feeling that these become more and more important nowadays, that you have to be sufficient in that. Now, if you want to go into academics, unfortunately or fortunately, however you want to see it, publications are the most important. If you don't have publications, if you don't have research focus, you will not have an academically successful career. This is something you have to be aware of. Quite different if you only want to go into clinical neurosurgery, which is obviously fine, then surgical skills and particular subspecialization is key. Even though we are less subspecialized than North America, but still this is definitely the way to go. And you also have to have management business skills to have a successful career there. So you should think about what's your way of where you want to go. And how do you get what you need? Obviously, you have to choose the right teaching institution. Very difficult. More difficult to find the right mentor. Without a mentor, you have a very hard time. When you talk about surgery in the past, when I was young and I was in training, we were observing, we were traveling, and this is one of the statements by Hennes Nemeth, that because he was sitting in the cold corners of different ORs in the whole world. This is changing now because obviously we have a lot of online content, we have a lot of social media, so you can really get good content nowadays. It may not be as realistic because people only show their best parts. So this is something you have to be aware of. Only if you really still visit a center, you will see the disasters and you will see the complications. You don't see them online. You choose a field or choose a subspecialty. Obviously, do as many cases that you can. And it's not the number of cases, it's what you make out of each single one. I always see young people saying, oh, but I only do so many or not that many. You can make a lot out of your cases if you really prepare well, think about them afterwards, and really, really make them a learning experience rather than just a number that you're doing. For academic careers, obviously, academic institution mentor is all the same. Focus even more important. People should know you for something. Collaborate. When you're young, you're still skeptical, and the new generations are better than ours in collaborating and finding. Have a plan. Don't just go out in the blue. Think about how you want to do it. Go to scientific meetings. Still nowadays, face-to-face contacts are important. And obviously socioeconomic competence, get involved, leading positions are important. So it's about talent, getting started with research, get help, have collaborations, and finish what you start. This may be the most important. A lot of young people start with projects, whatever, and then they don't finish them, they don't publish them. And as we know, if it's not published, it hasn't happened. So some general advice, and as I said, I try to be quick. Decide what you want. Make sure that you're willing to pay the price and don't find out later on that you are not. Family, work-life balance, all of that has to be taken into account. Of course, you don't know when you are in your 20s, but once you hit your 30s, you should. And choose your institutional mentor, most important there. You don't have to move around too much, have a base ideally, and very, very important, if you have a mentor or an institution, it's all about give and take. If you provide something for the mentor, for the institution, they'll treat you well. If you don't, they probably will not. It's always a two-way street, and this is something that can be an issue with young trainees and even young faculty. Be devoted, love what you do. If you don't love what you do, if you're not in it with passion, maybe more difficult. Set your priorities, go for sacrifice. Luck. People always tell you that they have had a lot of luck. I actually had a lot of luck. I know a lot of people that were lucky in many things, but for me, it's not about luck. It's more about grasping opportunities that are out there always, and usually fortune favors the bold, and you will learn that the older you get. Plan your career, think about what you want to do, have a research focus early, something that you're known for, and also subspecialize early, focusing on something, traveling, scholarships, fellowships, you name it. Get a label. That's what my boss always said. You should be known for something, and then you will have a successful career. This is true both in academia and in clinical neurosurgery, because if you're known for a certain surgical field that you're very good at this, you will be successful and you will have a good career. The earlier, the better. This may be a challenge as a young trainee. I see that. Stay on track. There will be disappointments. There will be lean times, and don't crack under pressure if you can. This can be also an issue. Publish or perish. Unfortunately or fortunately, again, however you want to see it, something that you didn't publish, you didn't do academically. Collaborate. Fix author research. That's a small advice there. Create a supportive environment. This is more about your private life and the team in the hospital, and also international collaborations. So there are many problems out there. Working hours, big issue in Europe. Attitude, work-life balance issues, of course. Number of trainees, you will have competitors. Financial research support, huge problem, particularly outside of those very well-developed countries. Be dedicated. And again, it's not the one surgical case you observe. It's not the one talk you listen to. But if you are seen at meetings on a certain subtopic regularly, people will get to know you. It will show your dedication, and you at the end will be successful. Be aware that even though you should collaborate as much as you possibly can, you are competing with others for jobs, for positions, and you're always judged in relation to your peers. This will never change. No, regardless whether you're in a more money-driven system or in a more academically or social-driven system, and use the days wisely, both in private and in professional life. So again, I thank you for your attention. I apologize for not being very concrete, but I was asked to just give you some general advice as a now senior chairman, how you can approach and prepare for an academic career. Thank you so much.
Thank you very much, Professor Tome. That was very insightful. For everyone watching, if you'd like further information about mentorship, amongst other things, please feel free to contact us as the Young Neurosurgeons, should we say, community, and we can point you in the right direction. So moving on, I think our next speaker does not need an introduction, but I'll give one anyways. So Prof. Hutchinson from Cambridge will be talking about rescuing the injured brain. He is a world authority on brain injury, and a lot of the stuff we do day in and day out in terms of management of TBI is based on the work that he's done in the field. So I will hand over to Prof. Hutchinson without further ado.
Great, thanks so much for the invitation. It's great to see the young neurosurgeons and the EANS flourishing. So thanks so much for asking me to talk. Can you hear me okay?
Yes, we can.
Okay. So, and does the slides show okay?
Yes.
Yeah, okay, cool. So I'm going to talk in a session which is called Neurosurgery in Low Middle Income Countries, Recent Advancements and a Look into the Future. And specifically, I'm going to focus on some of the work that we've been undertaking, predominantly related to traumatic brain injury, but also other neurosurgical conditions on behalf of the UK government-funded NIHR Global Health Research Group on acquired brain and spine injuries. This is a striking figure. On the 15th of November 2022, the world's population went over 8 billion people. What is even more striking is that 5 billion of those 8 billion do not have access to what we would call life-saving or disability-saving treatment, and specifically that is no access to safe, affordable and appropriate surgical and anaesthetic care. And that is due to a deficiency of funds globally, issues with access to hospitals, distance and poor transportation infrastructure, inadequate healthcare system, too few doctors, nurses, and other health professionals, access to medications, oxygen, blood. And, we're hearing a lot of exciting innovation in neurosurgery now, genetic engineering, personalized medicine, AI, but we need to be conscious that much of the planet remains in what we could call a healthcare time warp. The Lancet Commission for Surgery has put forward a number of proposals. This was put forward a number of years ago, Global Surgery 2030, and what is interesting is 2030 is actually approaching quite rapidly. There are a number of surgical procedures, what is called a must-do, should-do, and a can-do, and you'll note that there is a neurosurgical procedure that is commonly performed that is in the should-do category and should be available to any patient globally, and that is intracranial hematoma evacuation. I think Key Part will probably talk more about this. Key has done a tremendous amount of work on quantifying the number of neurosurgeons. That is approximately around 50,000. But there are major numbers of countries, 33 in this publication from 2019, that had no neurosurgeons at all. The UK government, through the Official Development Assistance Funding, have put funding towards a number of different research groups. There are 40 in total. These are some of the more surgically relevant across the whole breadth of surgical specialties and obstetrics. But from Cambridge, we run the NIHR Global Health Research Group on acquired brain and spine injury. So this is government funding which is designed to improve our knowledge and the needs of patients in low middle income countries. We focus on 5 different areas of neurosurgery: traumatic brain injury, traumatic spine injury, stroke, brain infections, and hydrocephalus and other CSF disorders. The group is run by myself, co-directed with Tony Fagaji from Cape Town and many other colleagues, some of whom are on this webinar, and really is designed to look at this huge issue of the terrible number of trauma deaths that are occurring per day. And about 90% of those deaths are occurring in low middle income countries, with TBI a substantial portion. This is the map that Tony has on his wall. It shows the globe the other way up to which we normally perceive it. That is absolutely fine. It is a globe in space, but is to emphasize this problem, particularly in sub-Saharan Africa. So we know some of the issues. We've mapped them through the group: delays to surgery, lack of access to CT scanning. How can we get around that? Intensive care, ICP monitoring, rehabilitation. There are a number of global institutional and government initiatives which exist to try and address these issues. The World Health Organization have a campaign on road safety. The FIA, the governing body for motorsport, have quite a probably under-recognized campaign of advocacy on road traffic prevention. And then there are other initiatives, for example, in India, looking at putting ambulances at set distances along a highway to try and improve pre-hospital care, and other issues. This is an example in Bangladesh with road safety measures, very simple things, including bridges over busy roads. More specific, the NIHA Fogarty, and then I'm going to take more time a little bit about the NIHR Global Health Research Group on acquired brain and spine injury. So the way we've set the group up is across 4 themes. The first is mapping care, beginning with a snapshot survey and then a registry, understanding care across the whole pathway, how we can generate and implement innovation, new technology that is cost affordable for low middle income countries. And finally, how do we build capacity in these countries, both in terms of delivering research, but also in terms of delivering clinical practice. So the first theme is data collection. We undertook a study called the Global Neurotrauma Outcome Study, and that has now led on to a global registry called GEO-TBI. So GENOS, this was led by David Clark, one of our resident doctors, but a number of our colleagues internationally who participated. And this is the largest cohort study looking at surgery for traumatic brain injury, with the countries divided into what's called the Human Development Index, very high, high, medium, and low. And we collected over 1,600 patients from 159 hospitals in 57 countries. And the first thing we find is a very difference in the mortality according to the Human Development Index of these countries. much, much higher in low and middle income countries. The mechanism of injury is interesting. The epidemiology of head injury is changing. In high income countries, this has become a disease of elderly patients falling, often on anticoagulants or antiplatelets. Other causes in low and middle income countries, road traffic collisions are becoming an epidemic, almost a pandemic, and a major serious cause of mortality across the planet. The time to surgery is quite shocking. These are the delays. The median time from injury to surgery is 13 hours. It is worse in the middle and low income countries, but there are major delays in high income countries. And I know that many partners in the EANS will also be aware of that, delays in getting patients to theatre. We have a very strong campaign of advocacy, cycle helmets, motorcycle helmets, seat belts, and the car seat campaign that Tony's running across Africa. Our second theme is looking at systems engineering, so we're able to map the pathways of care and try and improve them. That was pioneered in Myanmar. And then I talked earlier about access to technology. We take CT for granted. CT is not available universally. This is the infrascanner, a device which can detect blood clots within 3 centimeters of the surface. That we're currently pioneering in India, Guatemala, and Colombia. This is ultrasound to measure optic nerve sheath diameter connected to a smartphone. Optic nerve sheath diameter is a good surrogate for raised intracranial pressure. And then we are using simple mobile phones, SMS, text messaging in order to follow patients up. Other initiatives include teaching families to undertake rehabilitation strategies. And the final theme is the building research capacity. How do we get more data? Partly through courses. This is our first neurotrauma course that we held in Zambia in 2019. We've had subsequent courses. We've now increased the number of neurosurgeons at consultant level from 2 to 8, working with the Zambian government, Kuchinja Chericha, and my colleague in Cambridge, Ricky Trivedi. We are now embracing LMIC countries into clinical trials. So you'll recall the rescue trials. So the next generation of these trials now includes significant recruitment from international centres, and we're particularly grateful to our colleagues in Bangalore, in NIMHANS, where they see large numbers of patients. The impact is about advocacy at all levels, producing guidelines. The Brain Trauma Foundation guidelines are fantastic if you're in a high-income country, but what we need to do and what we're doing now is stratified guidelines according to resource availability. Lobbying at the World Health Assembly, Tariq Khan, who's a really influential member of our group, is going to talk about the work on TBI as a notifiable condition. And underpinning that, we now have this global registry, GOTBI, over 3,000 patients. Any hospital in the world can join the registry. You put in your own data for your own audits. We're collecting a larger database in order to just get more data to help lobby in terms of policy aligned to the TBI notifiable issue. The SBNS has a very active global neurosurgery initiative, was run by Nigel Mendoza. Chris Barrett has just taken that over. We have funding for fellowships and research projects, and we're delighted that we work with the EANS in terms of global neurosurgery curriculum and training courses. Swati Jain is working with the London School of Economics. Swati's going to talk a little bit later about some of the health economic analysis modelling. This is really important. If you look at the editorial makeup of the big neurosurgery journals, the lack of editors at LMIC level is quite sad. It's very, very low numbers. We need to lobby to get more editorial committee from LMICs. And, Gail Rousseau's been leading that, and neurosurgery now has this global neurosurgery committee. The Royal College of Surgeons have active global affairs and collaborate with the London School of Economics, the Global Surgery Policy Unit. It is very important that we move out of surgical silos and talk to other experts who understand how to model some of the important issues, particularly the finances, in order to generate income, improve policy and delivery of care. So in summary, to conclude, how can we achieve change through global neurosurgery? Prevention is absolutely critical. If you want to have a big impact, you have to advocate for helmets, car seats for children, look at how we can improve pathways of care from the scene through to rehabilitation, deliver RCTs provide evidence to change practice and encourage these RCTs globally. And if you do that, you can actually change practice with consensus meetings, again, traditionally aligned at high-income countries, need to cater for countries across the planet. The family-led rehabilitation strategy in India has been very, very productive. We're also looking at spinning that in other countries. Registries to collect data, as I said, GeoTBI is really, really important. And then we need to, in the future, look at other technologies that are going to be available universally to improve the diagnosis and treatment. We've proud that we've funded many fellows and neurosurgery researchers in 12 countries. We've generated a lot of manuscripts. As Claudia said, you need to publish, but beyond that, publishing is not the end of the story. Your publications have to result in impact and a change in practice from the data arising. So its publication needs to lead on to impact. Policy change, Tarek will talk more about that. But fundamentally, it's about developing leadership, working with partners and global leadership in the field of neurosurgical practice to drive improvements in neurosurgical care across the whole planet. We know the issues are significant: prevention, advancing care, and stimulating research. We've made some progress ourselves and many others. We need to strengthen these. The EANS is doing a great job, and we're really happy to continue supporting that. Reverse translation. High-income countries can learn a lot from low-middle-income countries. There is really high-quality care being provided across the world, and our UK trainees through the SPNS exchange programme are going out to other countries and learning new techniques, new technologies, and bringing them back into the UK. And finally, again, just to emphasize this point, research and publication is fantastic, but really you've got to make sure that your research changes practice and policy. I'd like to thank our collaborators, many universities and colleagues across the world. These are some of our investigator meetings that we've held. And again, please have a look at the GeoTBI website. Thanks again for the invitation to speak. It looks like a really good program. It's really, really hot in the UK. I noticed Tarek's got a jumper on, but I can assure you that here it is absolutely boiling, as anybody in the UK realizes. Anyway, thanks so much.
Thank you so much for that, Prof. Hutchinson. Are there any, I can't see any specific questions from the Q&A session. Does anyone else from the chat have any questions? Can I ask a quick question, Prof?
Yeah.
People are interested in pursuing from quite early on in their training a career in global neurosurgery. How would you direct them? What is the best way for them to get involved?
So global neurosurgery is not a defined subspecialty. It's an interesting specialty because it does cover many neurosurgical specialties, but delivered in a different setting. The way to get involved, as Tarek's nodding, the way to get involved is there are some research projects that ourselves and other run. You can contribute to the registries, but I think the most important thing is to try and take some time for observerships, fellowships, and buddy up with other centres and travel and go and visit these places. I know the SPNS offer it, the EANS offer it, observerships and fellowships. What I'm personally really keen is to try and introduce a system where high-income country trainee may actually buddy with an LMIC, get a relationship going, and you can actually exchange programs and join different ideas. So there are some fantastic opportunities out there. And I think the high-income country trainees can really, really benefit from seeing what goes on in other places.
Thank you very much. If there are no other questions, we'll move on.
Okay, great. Thanks so much, everybody.
Thank you so much again. We're really honored now to be joined by a distinguished figure in the field of global neurosurgery, Professor Tarek Khan. He's a consultant neurosurgeon with over 3 decades of experience in neurosurgery and a particular expertise in skull-based surgery. He trained in Ireland and in the UK, and now he's returned to Pakistan to pioneer neurosurgical services and medical education in the Khyber Pakhtunkhwa province. So it's a true pleasure and actually a source of pride for me being from the same country to introduce him. Professor, the floor is yours.
Hi, thank you. Can you hear me?
Yes, we
Yes.
can.
Yeah? And can you see my slides?
We
Yes,
can.
yes, we can.
Okay, thanks very much. Thank you, Sakiba. Thank you for inviting me. Just for the Hajj comments, the temperature in Peshawar is 40 degrees, but I'm up in the mountains, luckily, for the last 2 days. So that's why I'm wearing this jumper. So I'm going to talk about the public policy aspect of global neurosurgery and what we are doing together, everybody, regarding traumatic brain injury and traumatic spine injury, and how we have developed a global coalition, TBI coalition, to work to make traumatic brain injury notifiable, chronic, and preventable. So this is all the topics we are going to talk about. First of all, just a quick thing on the Genesis journey, where a conversation in Cambridge has led to all this. So we were in Cambridge at the ABSI launch in 2023, and myself and Tony Figaci from South Africa were talking about how there's a big gap and there's no unified global mechanism existing for TBI. And this led to a seed for the idea of a coalition. And at the INTS again in Cambridge in September 2024, we formally launched it in the conference after meeting with the Brain Injury Canada Consortium and making the campaign and coalition formalization, announcing to the global health community. And then in November 2024, at the G4 Alliance meeting in Peshawar, we made it G4 working group on TBI. And since then, we have been having regular meetings, and the coalition has been growing. And in May 2025, we had a WHA 78, where every year the people meet for the World Health Assembly. We had a meeting, the first meeting, and which was very, very successful. And now we had a WHO regional consensus where I spoke at the Eastern Mediterranean region WHO office, and people from Indonesia spoke in Fiji for making TBI resolution. And we are now looking towards the executive board meeting of 160 and the WHA meeting 80 in 2027 to consider a resolution for formal agenda inclusion for May 2027 adoption of TBI as a notifiable and chronic condition, creating the global mandate for prevention, surveillance, care, and accountability. So this was just a quick structure how it went, and we have 40 plus organizations now with 500 plus in May individual members of this coalition. And the important things were that we have persons with lived experience positioned as co-chairs from day one, and they are really our voice. And of course, the G4 Alliance integration and making the lower and middle income countries the first architecture, building it around the zones of EMRO, EFRO, CERO, and WIPRO, and knowing that road crashes, falls, and occupational injury survivors are the core. And because of the papers written from this coalition and Lancet and Brain Science publications, Sarah was instrumental in that. It made it technically credible before pursuing our diplomatic momentum. So our mandate was to get a minimum data set indicators reporting, to have a harmonized policy, to develop a communication advocacy group, persons with lived experience, develop a storybook, and strengthening partnerships with WHO, NIHR, G4 Alliance, member states, global organizations. So the structure developed by itself really, and I think it is a good structure. We have the Global TBI Coalition, and then we have a small group with a policy working group working closely in technical alignment with the WHO. And then we have the community engagement involvement with the person with lived experience, where they are in every place where we talk. We have the person with lived experience talking first, and then we follow them. And then we have a communication working group, which is really, really led by the Cambridge group, advocacy assets, media, events, storybook. So the really global position papers made a big help. Then the drafting of the WHO resolution on TBI, which is being technically revised at WHO guidelines, and then the PWE storybook. And then we looked at geo-TBI, and from them we got the minimum data set and core indicators for surveillance. So we all know the invisible global emergency. I don't really have to go into that, but we know that estimated global economic loss due to TBI between 2015 and 2030 without improved prevention and care is $4.4 trillion. So we looked at it to reframe the whole thing, because we have been, as neurosurgeons, talking about the acute event, treated in ER, discharge, case closed, no follow-up, no rehab, and under-resourced, and really missing from our national health information systems. But it is a lifelong chronic disease, this cognitive decline, epilepsy, depression, employment and education loss, long-term rehabilitation, social participation, requiring national surveillance. And as one spouse caregiver said, nobody tells you how isolating caregiving is. You disappear from this world and people stop asking how you are. Also, we know that what we measure versus what remains invisible. So measurable is hospital mortality, severe case admissions, acute care costs, surgical intervention. But invisible mild TBI prevalence, which I have started now working with in the ABSI group on that, long-term disability, social economic impact, rehabilitation outcomes are not available really. So why make it notifiable? So we cannot really manage where we cannot measure. So notifiable status transforms all this suffering into visible data. It gives us visibility. From there, we can develop policy, and from there, we can unlock funding for rehabilitation, prevention programs, and long-term care infrastructure. So this is the most important thing. We have to engage the World Health Assembly and different events and get diplomatic traction. So last month in May, we had a very good session, a side event at Geneva. And thanks to, again, Hutch and their team for providing the financial assistance and many other things. And we had 335 people registered. 10 countries were represented by ministries and ministers. And last year, we had only one minister. We had 50 plus organizations, and the Eastern Mediterranean regional director was there also. So there was public, it was led by Pakistan Ministry of Health. There was public endorsement of the resolution, expanded sponsor support discussions, regional support signal from MRO leadership, clear and next steps were identified. So senior ministers were there, and it was the moment when TBI moves from expert concern to political mandate. So, and the important thing was that 4 of those people who were attending are hopefully contesting for the Director General of the WHO next year. So we hope that we have the inside track from these ministers who were there. So the message was that it should be a measurable burden. We know that it is a solvable policy gap through countries acting through prevention, emergency care, rehab, long-term follow-up, and that it's a pragmatic WHO ask. The resolution requests guidance, indicators, and country implementation support rather than only recognition, make it actionable, and that the coalition is already ready there to help them. So some of the countries, Pakistan, Turkey, Indonesia, Italy, South Sudan, Qatar, Tanzania, Guatemala, they agreed to sponsor. Also, then following that, Nepal agreed, Cambodia agreed, and Syria agreed. And we are in engagement with UK and with Norway. So we are looking at really help for many other countries, and we're working on that. And of course, we'll be requesting you also to look at any countries you know who can help us with this resolution. So these were the ministers and everybody. And very important, this coalition is not a neurosurgical coalition. It's a coalition of persons who want to improve traumatic brain spine injury care across the globe. So they are NGOs, they are persons with lived experience, they are neurosurgeons, they are diplomats, they are, as I said, persons with lived experiences, and all forms of society, people who are there, who are working on that. So we are now working with the WHO and we are trying to align with them. We met with their one of the groups, Neurology, Sensory, and Oral Department, align with WHO mandates, make the data practical, and then clarify the implementation asks and strengthen the evidence package. So we all as a group are working. We have meetings regularly every 3 weeks, and we are working with the WHO as well to try and figure this resolution. So, of course, the timeline is very strict now. Again, we have the evidence package, which is really ready. We have the sponsor coalition already ready. And we will be looking at the Geneva missions capitals in September. And we hope to submit the resolution as an agenda item. And we hope that the executive board will work on that. So in June, July, hopefully this month now in June, we'll finish the resolution, finalize it, give it to the sponsors, which is the government of Pakistan. They will be sending the resolution to the executive board in September. And then in October, November, they will be consulting. And we are trying to get as many members of the executive board to be on our side. And they will be sending that if they clear it in January, it will be looked at the executive board. And if they approve it, then this resolution will be sent to the World Health Assembly, which will vote on it in May 2027. So we have revised the text. We have developed the evidence brief. We've got the lead sponsor. We have the co-sponsor outreach, executive board submission. So all this is going to be worked according to this pathway. So we have all these. We have got the sponsors, co-sponsors. We have got the regional anchors. We've got the technical allies. And we're working with the ministries. And we're trying to even further increase the coalition. So the engagement assets are 1-page political ask, 5-page evidence brief, revised resolution text, mission briefing deck, endorsement list, and expert roster, country-specific talker points. So all this we have been learning along the way. So I think this is very important for you young neurosurgeons, that if you tomorrow are going to ask for a resolution on the World Health Assembly, you should know how this happens. So of course we are working. We have the political leads now. We've got the coalition leads. We've got the technical leads, and we've got the operational leads. Our secretariat lies in Cambridge, and everybody is together working on that. So the risks were that the resolution should not be too narrow. Member states, please let me know when my time is up. Member states prefer broader agendas, so we are framing TBI within public health, brain health, injury prevention, emergency care, rehabilitation, and universal health coverage, and asking for the minimum data set. And we are trying that the sponsors do not get fatigued, because if the timeline slips, then it might get difficult. And text should not be technical, because the diplomats need clear political value, not medical detail. And we have done that. And we want to have same message going across, so there's no coalition fragmentation. So this is how we are doing it: 30 days, 60 days, and 90 days. In 90 days, we want to have the EB ready, submission package, refined text, and then live country outreach program. So we have the global political recognition, want to help improve data systems, catalyze national policy, mobilize funding, empower lived experience, care, continuum integration. So this is what we will achieve with the WHO resolution. And of course, for the countries, it will be added to national notifiable lists. It will develop national TBI surveillance registries, integrate into national HIS, and of course, we're looking at GeoTBI to help us, or also the WHO thing, and strengthen trauma rehab continuum, and of course, resource person-led experience. And then the countries will report to WHO annually. So a global mandate for change: TBI is preventable, chronic, and life-altering. Recognition is the first step to accountability. Notification would unlock the data needed for effective action. And we want to thank the G4 Alliance, the NIHR ABSI Group, PTSSC, coalition partners, endorsing organizations, ministries of health, person with lived experience, Northwest School of Medicine. These are some of the organizations which are supporting this, and they keep on growing with time. So thank you very much. If there are any questions to this, that's my email. We would love it that if you can join this coalition, all of you, and also if there's any countries you know who can help us with this coalition. Thanks very much.
Professor, thank you very much. That was very, very useful. Can I ask a quick question? In terms of the impact on us as young neurosurgeons, what do you think coming out of this policy will be the greatest impact on our practice as young neurosurgeons going forward, say in the next 5 to 10 years? Would it be on TBI prevention, so we would see less of it, or is it going to be more about the availability of resources to treat it afterwards?
Yeah, thanks very much. So obviously, the most low-hanging fruit is the prevention, because we know that maybe 80%, at least as far as I'm concerned, from lower and middle-income countries, those TBIs are preventable. So if you work on the prevention aspect, which does not cost very much, I think the burden of disease would be reduced, and there'll be more place and more overtime for other disease parts of neurosurgery which are important. And of course, very important, the real work starts after the passing of the resolution, because then we have to start convincing the governments. But if we have this resolution, then we are on a stronger footing to be able to talk to governments on that. And of course, we are looking at the whole aspect of it, prevention, and of course, acute care, right from the roadside to the ICU to theater, and then most important, rehabilitation, which is there. But of course, as I said, the low hanging is the prevention. Thank you.
Okay, thank you very much. Are there any other questions?
I wanted to ask Professor Khan, what do you think about governments and countries implementing the things that will come out of the policy? As Professor Hutchinson mentioned, like building bridges over the busy streets. Is it going to happen in reality, as it's probably the most important part of the prevention?
Thank you very much. Yes, I'll just give you an example quickly of the folate fortification resolution, which was led by the neurosurgeons and was passed, I think, 2-3 years back by the World Health Assembly. And they're continuously pushing the governments, but using that resolution. So we are very hopeful, because every year the governments have to report back. It's not a mandatory resolution ever, but they have to report back to the World Health Assembly on what they have achieved. So we as neurosurgeons and all people who want to improve neurosurgical healthcare with this resolution can be pushing the governments on safety measures, on seat belts, on helmets, on, as you said, building bridges, and everything aspect of that. So I think we'll be on a very stronger footing to do. Presently, only Australia is the only country where this disease is notifiable, really. Thank you.
Thank you.
Okay, thank you very much, Professor. We'll move on to
Thank
our...
you.
Thank you very much for joining us. I appreciate it. It's probably quite late in Pakistan, so I'll bid you farewell. So our next speaker is Dr. Key Park. He's a globally respected public health advocate. He's an expert in global neurosurgery. He serves as a lecturer in global health and social medicine at Harvard. And we're really pleased that he is joining us from Seoul to talk about the future of neurosurgery and LMIC.
Can you all hear me? Yeah. Can you see my slides?
Yes, we can.
Okay, great. Thanks, Sakiba. I really enjoyed the last 3 speakers, Tariq and Peter and Claudius. I learned a lot myself. Hey, so this is an interesting program. I when I first got the invitation, said we want to be, prophetic, right? What is the future of neurosurgery and LMIC? So I think this is fun. We get to predict what it's going to be for, people like you, when you get out of residency. So there are some things that are happening which I think guides in these prophecies, and then I'll get to some of them now. So one thing is, someone had asked, how do trainees and students get involved in global neurosurgery? Well, lucky for you all, there is now a International Society for Global Neurosurgery, ISGNS dot. I'm sorry, that should be COM, ISGNS.com, COM. If you go there, you'll see this new society. Tariq and I are in the leadership of this organization, and it's really for there's a membership for trainees and students, and the dues are modest, and it's scaled based on the income levels, and there are many opportunities for the next generation to get involved. We even have a committee, Next Gen committee, with the chairperson of that committee being sitting on the at the leadership level, and we want to be very closely engaged with the young people. So that's how I would get involved. The global neurosurgery, which is defined as the clinical and the public health practice of neurosurgery with the primary purpose of ensuring timely, safe, and affordable neurosurgical care to all, wherever, whenever. It is now, it's been 10 years plus since the Bogota Declaration in 2016. Tariq was there, I was there. And that was a call to action. And now global neurosurgery has really become institutionalized in our profession. I would take issue with, I think it was Peter who said it's not its own specialty. I think it is. I think it really is. So I'll show you why I think it is. So a lot of people think of global neurosurgery as sort of mission-based activity. And that's how I got started. I was doing some medical missions and short trips through the EANS, but it's a lot more than that. It's that plus. So we talk about short-term service trips, but these kind of service trips, if you limit it to those, rarely solve the systemic issues. And really, it's about moving towards a public health approach to strengthen systems. So, future of LMIC neurosurgery depends on things like national planning, policy, partnerships, and local training ecosystems. And as Peter said, it emphasizes translational research, policy, and implementation rather than isolated clinical activity. So it's clinical and the public health practice of neurosurgery. So here's what I'm predicting for the next generation of neurosurgeons. I think your careers, some of you will be involved in advocacy, data, and implementation science, along with technical neurosurgery. Field already is bridging research, governance, and practice, and you saw Tariq Khan talk about that. The research that has shown TBI and the burdens and the economic costs, those all now feeding into the WHA resolution, which Tariq is leading this group and is doing an amazing job with that. So global neurosurgery now spans a lot more than just clinicians like us, trainees and researchers, nurses, policymakers, implementers. It's a huge, a much larger coalition, as Tariq said, than traditional subspecialty silos. Global neurosurgery is actively about de-siloing our profession and enlarging the tent. And this has significant implications. I'll show you in a little bit in terms of research and impact in research. And really, what I think will happen over the next decade or so, right now, a lot of the global neurosurgery conversations happening at high income country institutions where I sit. I'm at Harvard Medical School, touch with Cambridge. It really needs to be flipped eventually, where countries lead. Pakistan, Zambia, Uganda, they lead. Regions will coordinate, like the WHO regional office. They will coordinate amongst themselves in region. And countries like US are actors that are in high-income countries. Our job will be eventually to support, but definitely not lead anymore. So some of the competencies mixed by 2030s. This is, of course, completely speculative. We all have to have clinical excellence, right? We are surgeons at the end of the day. But some of you will be excellent in research. I just estimated 50%, but it could be up or down. policy literacy, people, who will follow after Tariq's footsteps and then be able to engage in an intelligent way with policymakers, global health governance, and then public health practice. These are competencies that we are now starting to see increasing over time. I think the training and the way the curriculum for residencies are going to be designed will eventually include these elements. Okay, so let's talk a little bit about research. This is, if you go to PubMed and then you punch in global neurosurgery as a keyword, there's been an explosion of number of manuscripts, the papers that have been published over the last decade or so under the heading of global neurosurgery. There has been a creation, in essence, of a new academic subfield of neurosurgery called global neurosurgery. There's no doubt about that. And it's not just about quantity. There's actually a high impact. And this is why. And I'm going to brag a little bit about one of our papers that we published about 10 years ago. It has to do with estimating the global incidence of traumatic brain injury, which is, in fact, one of the papers that Tariq and the policy team used for TBI resolution. It's one of the references. This was published in the White Journal of Neurosurgery, 2018, I think it was. And there's a thing called altmetrics. It's 774. I have no idea what that means. But if you go and just go down the rabbit hole and click on a few things associated with this altmetrics, it tells you a few things. One is, it says of the outputs from Journal of Neurosurgery at the time that I checked this, and in fact, it's not now 2, not number 3. It's the second most impactful paper of all the papers from the Journal of Neurosurgery that's been analyzed through the altmetrics, as a platform. That's incredible. We might even be number 1 because we're just less than 10 years old, and this particular paper has been downloaded full text views over 80,000 times. Okay, so we didn't have any money at the time. This is still behind the paywall. And I just did a back of napkins, analysis. And if it's $45 for download, 86,000 times, the Journal of Neurosurgery potentially could have brought in revenues close to $4 million for that one particular paper. So, I mean, I need to speak to somebody about this. I need some commission because they didn't pay for this research. The point is, global neurosurgery research is highly impactful in terms of citations or metrics, driving policy change. Why? Because we're not only talking to neurosurgeons, we're talking to neurologists, policymakers, epidemiologists, right? People, social scientists. We are now growing beyond our technical area of expertise, which was OR, operating room, and neurosurgical conditions. But now we're talking about the public health practice, and a lot more people are involved with that. Okay, so I'm going to finish with a couple of quotes. The future of neurosurgery in LMICs will be built less by visiting experts and more by locally rooted leaders connected through global solidarity. As this sort of goes back to what I said earlier. And my last message to you is: we build systems, not dependency. Global neurosurgery has moved from a nascent idea to an organized professional movement, and the responsibility of this generation is to make equitable neurosurgical care normal, not exceptional. Thank you.
Thank you so much.
Thank you.
Park. Any questions from anyone?
I have one. Thank you so much. That was really really insightful on the work that's being done. My question, and it's a recurring theme on some of the questions we get in the chat, because obviously most of the people that are watching us are people at the start of their careers, like medical students, junior trainees, and they are worried about how the activities they do now can help shape or impact their future careers and their future trajectories in their training. So getting involved, for example, with organizations like the ISGNS at such an early stage, because obviously you talked about the local leaders, the leaders of the places that need to be built up and play a role in the future. How do you feel that getting involved at this stage, for the people in our audience, getting involved, how would that help them get better and get into how would that impact their careers down the line, their training and careers?
I think it's a positive thing. It's not for everyone, Evangelos. It's probably 10% of in a given room, right? And someone gets up, and says, "I want to do that. That I'm interested in doing that kind of work." So for the same reason, I remember when I was a resident, someone clipped an aneurysm, deep down in the basilar tip, and I'm like, man, I want to do that. Right? It was cool. And now we have an option of people who maybe want to get into that neurosurgical equity and solving for that equity and getting involved at the resident level, student level. Remember, you don't have to know how to clip the aneurysm to talk about and advocate for better neurosurgical care for everyone. Anyone who can write can be could contribute, can do research. I remember, the paper that I just quoted cited that half the authors there are students and residents. So there's a lot of opportunities here. But I think Tariq and Peter may have a few comments.
Can I make a comment, Key?
Yeah.
The subspecialty is an interesting concept, and what I was alluding to. So traditionally, we have neurovascular, neuro-oncology, skull base, hydrocephalus, and these are with fellowships, and they're sort of recognized at a board level across many countries. So the point I was probably trying to get across is, do you think we could get global neurosurgery as a formally recognized subspecialty within neurosurgery? And how would we go about? Because that would be a major advance, even if it's a second subspecialty, to get it formally recognized in terms of people's efforts. Any thoughts on that? And that was a great talk, by the way. I think, yeah.
It lends itself to be sort of an add-on specialty, doesn't it? You could do it
But it shouldn't be an
standalone.
add-on. It should be a core, Yeah.
Yeah, you could be a vascular neurosurgeon and still be a global neurosurgeon because, right? So one's about how to do surgery better, and one's about how to better deliver surgical care.
Yes.
So they're
Correct.
two different things.
Yeah, correct.
I would just like to add, it's the most important thing for neurosurgeons in LMICs because they have to understand the public health part of neurosurgery because they're the one who are able to shape policy in their own countries. They're able to speak to the health advisors and shape neurosurgery or global surgery general surgeons. So I think it's very important for the people, the neurosurgeons and LMICs to understand this. Thank you.
Perfect. Yeah, that's a really important point. Thank you all so much. That has been really informative, and I think a good point of directing our thoughts towards. We're going to move on to the next speaker. I'm really happy to be introducing Swati Jain. She's one of the colleagues that I've met and have truly been impressed by her work and by her work ethic. And she's a neurosurgeon from Singapore. She works there as a specialist, as a consultant. After spending some years in Cambridge doing her PhD and a couple of fellowships. And she's done brilliant work within the field of global neurosurgery, and we're really looking forward to her talk. Swati, thank you so much for joining us.
Thanks, Evangelos, for inviting me. Let me just share my screen. Right. Sorry. Oops. Can you see my screen, Evangelos? Sorry.
We can't, no.
No.
Okay,
not
so
yet.
how about now? No, okay, just give me 2 seconds.
Oh, yes, we can see it now.
You can see it now, yeah?
Yeah.
Okay, I'm just going to put it in presentation mode. I think it's just lagging a bit. Sorry, just give me 2 seconds. Okay, it should be in presentation mode now. Is it all right, Evangelos?
Not yet. It's
Just about. I think it's going to come through soon. Just a lag.
Yeah, that's fine now.
Right.
Thank you.
Okay. All right. Thanks. Thanks a lot, Evangelos. Sorry about the technical difficulties. I am very glad I'm going after Prof. Hatch and Prof. Tariq as well. And I think they have kind of set the landscape of what global neurosurgery holds for us. But when Evangelos asked me to give a talk about some of the work I have done while I was under NIHR and with the University of Cambridge, with obviously Prof. Hatch's support, I thought one of the things I will talk about today, especially for the global audience here, and I think one of the biggest questions that was raised just about at the end of Key's talk is how can we be useful as neurosurgeons? Because, I'll just give an anecdote before I start my talk, is that I actually tried applying for MSF and I sent them an email asking them, is there a way I can volunteer for you? Maybe just a couple of weeks, to try to do some surgeries as a resident, being excited, being in a place where our normal drills don't exist. I have to use a jiggly saw, and I just wanted to kind of play around with it. And the email I got back was very interesting because they told me, right, can you deliver babies? Can you do exploratory laparotomies? And I was like, well, I did it when I was a very young surgeon, but obviously not anymore. And that's when I realized we as neurosurgeons are sometimes considered not very useful in our fields because we are considered to be very, very subspecialized and with very little resource handling, especially for us who do come from a high income setting. And that's when I started exploring what are the other ways which I can make myself useful. And I think I'm going to repeat some of the work that has been presented, but I just wanted to show you that this is one of someone I really respect, Prof. Nigel Rossiter, who has basically established one of the NGOs called Primary Trauma Care Foundation. And this was published about 6 years back when I got involved. And I thought, this is something really interesting because we do forget about it. We do forget about trauma. It's unless you have an interest in it, most of the time, if you ask any neurosurgery resident, they'll be like, yeah, I did one craniectomy last night for an acute subdural, but people don't really put all their heart into it. And I think all the panelists who are here, especially talking about the LMICs, they know how much TBI contributes to the bad outcomes that we see in the countries. And this is one of my favorite slides because what it shows is most of the trauma happens where most people live. And I think that is very true for most of the low and middle income countries, especially if you go to the cities, the roads are not going to be nice. The traffic is not going to be very well placed as you would see in UK or in Singapore. And that's where the difference comes as to how we can make a difference. And I think this is just trauma by the population size. I think Prof. Hatch showed you the map about the surgeries of TBI that is done based on the income settings. And as you can see, most of the trauma actually happens where there are not many resources. And if you see, my Singapore is really, really, really tiny somewhere over here. And it's not even on the map for this one because trauma is not really a big thing in Singapore. And just to tell you that if a good pre-hospital care is actually introduced, it is actually really, really cost effective. And I'm not talking about TBI alone. I'm talking about trauma as a whole. And as neurosurgeons, even if you're not good at doing other general stuff, we're not good at delivering babies, we're not good at opening up the tummies, we are definitely good at managing trauma because that is how we are trained to approach a patient. And most of the conditions that impact people in low and middle income countries are actually treated by emergency care. And this is what World Health Organization has been pushing for. So the latest World Health Assembly again talked about basic emergency care that should be delivered to these patients in LMICs and improve their clinical outcomes. So again, this is actually a really true picture, which one of the colleagues from my NGO, which is Primary Trauma Care Foundation, took, where this patient was basically hit by a car. Can you see there's no cervical nursing for those of the residents around there? There's nothing, making the scalp wound better. All you see is a drip, not in a sterile environment, and clearly there's no log roll that's happening. And this is how the patient is being wheeled into the hospital. So one of the things that I volunteer for, which I thought I will talk about, is called the Primary Trauma Care Foundation, which delivers the primary trauma course, which is very similar to the Advanced Trauma Life Support System, or the ATLS that you know about, and also the European Trauma Life Support System course, which is very famous. And both these courses, one of the biggest thing is the charge, right? For ATLS, for example, you pay nearly $1,000 to get your certificate to be able to teach ATLS if you want to. But I mean, if you look to any of the war zones right now, do you think anybody in Gaza is going to be able to pay $1,000 to get certified? Do you think anybody in Ukraine is doing any of the trauma care without actually having the certification from ATLS? So that's where PTC comes in, and it's all about no charge to the participants. It's to use what's available. So it's a very resource-dependent course, and we use local faculty with local instructors. So like Prof. Tariq mentioned, it is very important every time you do any kind of global work, you do involve the local faculty. You cannot be the savior who flies from one end of the world, ends up in the middle of nowhere, and you're trying to teach them using things that they have never seen or they don't exist. You can run a very nice trauma code in Singapore with 5 nurses, 2 trauma surgeons, 1 emergency care physician, 1 neurosurgeon, 1 orthopedic surgeon. That doesn't exist. You know, if you were to land in sub-Saharan Africa, in Uganda, for example, it's just that one surgeon who is playing the role of the emergency physician, playing the role of a nurse, playing the role of the first responder. So it's very important to know what your local resource looks like before you develop anything. And it's all about training the local personnel, because you will leave. You might not have funding to ever go into the middle of nowhere. Your NGO might go away because of the changes in political situations around the world. But if you do not train the local faculty, you're not going to change the system, and you're not going to make it better for the patients. So the way the PTC run is, it's very interesting, right? So it's very different from how we are exposed to most courses. So it's called Training the Trainers course as well. So it's run over 5 days. You teach a group of people who are tested for 2 days. Then you choose about 10 people from this group who you think are good enough to become instructors and carry on this course for their local participants eventually when you fly off and never to be seen again. And finally, you do 2 days of this course again, where you're just the faculty in the background, but it's actually led by the local instructors. So this is what usually it looks like. And this kind of covers the entire modules of ATLS. And why I am showing you this, you can imagine the head injury is module 6, which is really, really, really tiny. But I realized this is something I could be useful in, because I can teach most of the stuff, even though I may not know how to do the surgical bits of things. And you can train people and try to change the local climate to improve outcomes in these patients. So it's been going on from 1996. And if any of you want to volunteer, you can go and look up at the website. Either you Google as Primary Trauma Care Foundation or the Life and Limb course. And basically, you do have to attend one of the trainer courses, and then you become part of our faculty, and we do involve you to become local champions and subsequently train people in your own country or nearby locations where you find feasible to go. And unfortunately, it does remain the single largest unaddressed global healthcare issue at this point of time. And as you can see, the changing political situation, the increasing number of wars, we hardly know what's going on. I think most of you would have read the earthquake in Venezuela, and you can imagine the number of trauma centers that will need to be set up just to deal with all the casualties that are coming through. So I've done this in a lot of places right now. I think I've done it about 6 times. It's not easy, but you can see these are the places I would never venture into unless and until I was doing something related to this. So just to tell you what resource utilization means, I just wanted to show you a set for tracheostomy. So this is how a normal tracheostomy set looks like. But if you look at this, this is what we made out of a Pringle box of chips. We put in a sponge board on this, and these are just paper clips because we just wanted to feel the different textures and to look at the rings. There's actually a pipe that I actually bought from a hardware store to try to put it in and see if that works. And that worked really fine because this was too expensive for them to carry on. This is us. This is one of my colleagues who I've done most of the courses with. And we wanted to talk about cervical immobilization. And they didn't have collars. They had nothing. There's no sand around in that area, so I couldn't get sandbags. So the only thing we had to come up with was the rice bag. So we had to say for the 2 days of the course, please do not take the rice home because I need it for the course and for cervical spine stabilization. So this is how we teach most of the things. So as you can see, we do teach them manual stabilization. This is us doing a pelvic binder without using a pelvic binder. And this is us running some of the moulages for them to understand how to deal with a TBI or general trauma in that matter. So this is us just becoming volunteers as well, because sometimes you have to teach them how it feels like when they are volunteers themselves. So we went ahead. So this is Mr. Andy Kent, who's an orthopedic surgeon up in Inverness. Again, he obviously volunteers with the Royal Air Force, and we did this in Cairo. And you can see we always have to improvise. So this is us teaching them how to do chest drains. So we actually went to a butcher shop and got a camel's chest in Cairo because that was the best chest that was available. And that's how we modified the resources, because we didn't have a chest drain set. And that was the only way we could actually teach them how to do this. So this is, again, this was my modifiable chest set in Addis, because the problem was that I couldn't bring animal stuff in Addis. So I used a cardboard and bamboo bits to actually teach them about the chest wall. Again, this was a modifiable tracheostomy set, just using very cheap stuff. I got it from a hardware store. So this is us. This Chris, who is actually one of the emergency physicians, was volunteering as a pregnant female because that was the only volunteer available who could mimic the physiological demographics. We do make them teach. And this is one of the things we asked them to teach was how to do a handstand, because it was all about learning how to teach, because that's a skill as well. So what are the good things about doing this? So of course you explore bits of the world, and I'm not going to say that is an attractive quality of doing global work, because, you are going to go to places that is not a tourist destination. I've met people, made friends, which have indeed lasted miles and across continents. I've gotten a text recently where one of them actually texted me that I managed to take care of the patient and he's doing very well. I saw him on the roadside. I did cervical spine stabilization. He managed to make it to ED, didn't have any neurological deficits. And I feel, look, it's never going to be glamorous, right? Like the news reporter is not going to come to you because you went to a small town in the middle of Uganda to teach just how to manage trauma, because you're not hearing the bomb sirens, you're not hearing gunshots, you're not doing, cricothyroidectomies, you're not putting pens in people's neck, but you have made a difference, and that is good enough. There are always bad things as well. Things will not always pan out. Things will get cancelled. Equipment will be very different to what you expect. There was once I was told I'm going to a room. In the end, it was just a shed. There was no room where I could actually do. You might have a pit to poo and pee in. And this is something, it's very important. If you are going to do field work, you have to be very, very clear. You are not going to get the comforts that you get back home, and the message may not get across. So why do I still do it? Definitely because of the good things, not the bad things. And then it comes to neurotrauma. So I think the 3 lectures before me already have made it very clear that limited resources and TBI being not very well understood has always led to very poor outcomes. And so we decided to come up with a course which taught basically the principles of management for brain and spine trauma, and to cater it to the audience depending upon what their skill levels was. And it was mainly to manage where neurosurgeons don't exist. So we planned it over 2 days, but we obviously extended it to 3 days if the audience was good enough and wanted to learn some extra skills. And this is how a 3-day course looked like. So the first day we focused on brain injury. The second day, obviously, we focused on spine injury. We extended it to a 3rd day if they wanted to learn some fixation and a bit more of spine surgery, which tends to be a very, very niche skill set. And so far, we have done it in about 4 places. We started with Cairo, and we recently ended up with Moshi in Tanzania. We do a pre- and post-course MCQ to actually assess if they have learned something. And I'm just going to show you some pictures before I end my talk. So this was in Cairo. So as you can see, there were 5 people. This was actually the head of the Palestinian Red Crescent Hospital. She's actually a cardiologist by training, and she said to me, look, I have no clue how to manage a TBI. Can I be part of your course? He is actually an OT nurse who does mostly deal with trauma, but wanted to learn more about the TBI. And this is actually us going through some of the Asia grading and teaching them how to fill the form. Obviously, we wanted to learn how to do burr holes. Please, no animals, but these were meant to be meat eaten, and we actually went to the butcher shop and we got 2 of the cow heads and one smaller cow head, basically to teach them how to do burr holes. And we actually managed to see quite a fair bit of good anatomy because this was really fresh brain, so you can see all the cranial nerves going here quite cleanly and nicely. We obviously went ahead to do it in Lusaka. This is Mr. Trivedi, who has been instrumental in helping us do this course. And again, this is us going through all the stuff that I talked about. I managed to bring some heads. So this is a Rovina head. For those in UK actually know about Rovina, which is a training module, but I had this head for some other reasons. And this is us teaching them how to do burr holes. We also had Nicola, who is actually one of the resource nurses in Cambridge, who came along to teach the nursing aspect of things, because that's really, really important. You know, they need to know how to manage patients in the long term, not in the acute care itself. And of course, this is us doing some moulages and some questionnaires to see how much they have understood. And of course, this is my entire team that went, and this is Dr. Fahim, rehab physician. Again, you cannot take rehab out of TBI. The cognitive rehab, the subsequent back to functional outcomes is extremely important. So I just want to end my last slide. You know, obviously this, I would not have been introduced if I did not meet Mr. Nigel Rossiter. Andy Kent, who has literally been one of my biggest supporters, and he has been coming to most of the trips with us. A lot of the work was actually sponsored by International Medical Corps. And of course, the Essentials of Neurotrauma course won't be here without the NIHR group, without Mr. Ricky Trivedi and David, who has basically we have co-developed this course coming together. That's my contact email. Happy to take any questions if there's no time on the later thing. I think there's just one thing I wanted to, because I didn't want to take the time, was I just wanted to say about Prof talking about global neurosurgery. I think one of the things that a lot of people have asked me is that when they do go for global neurosurgery fellowship, they feel that they're not really recognized, or it takes time out of their training. So having a formalized certified time, which does contribute or adds to their list of training things that would have been done, I think personally, I feel that might be a really good thing, whether it comes under the term of having a second subspecialty or just being recognized as a formal fellowship if they spend 6 months away from their training institute. I think that would be really good. Yeah, that's all from me. Happy to take any questions. Yeah.
Thank you very much, Swati. That was an amazing talk. Just following on, obviously, from Prof. Hutchinson's comments on the fellowship and now yours. So for people, as someone who also wants to do global long term, I've had a few people approach me and ask questions and make comments about what global neurosurgery really means, and it's quite confusing because people seem to have this idea that if you're going into global neurosurgery, you are then coming out of clinical practice.
Yeah.
And really what you're doing is you should be pursuing it from a public health perspective. But then that means that all the years that we put, hard years of training that we've put into making ourselves surgically competent, they feel like a bit of a waste. So I guess that this is to all our panelists from the LMIC talks. I guess, what would you advise people who want to do this long term, but also want to continue to practice surgically? Obviously, that means practice at a decent level and enough to remain competent and to keep up with their competencies.
I think if I start first, then I will obviously leave it to the esteemed panelists to talk about this. I think one of the things to understand is not to box global neurosurgery, that it can be defined as one definition. So global neurosurgery is not just policymaking. Global neurosurgery is not just doing research. Global neurosurgery is not just doing surgeries. And I think one of the things that Key said at the end, it's very, very important that you can't just fly in, for 5 days and say, oh, I've done these 5 surgeries. I've done a bit of global neurosurgery, and you're back to the to your work, so that you can carry on and be a vascular neurosurgeon or a glioma surgeon. Okay, I'm a glioblastoma surgeon, but in the sense, it's very hard to part with things that you've learned and spent a lot of years doing, and rightly so. You don't want to give that up if that's what is passionate to you. But at the same time, I think it's about making that decision, what balance is good for you. So for me, I think one of the things that has always attracted me is education, because I feel that is something that can really change people, because you can actually educate them to improve practices at their end, right? So I can't be there all the time. If I can empower them to improve their clinical outcomes, to improve their surgical skills, that is good enough to me, because it's not glamorous. Like I said, it doesn't feel glamorous because, I am not being lauded. I'm not in the newspapers or media channels doing surgeries in the middle of nowhere. But to me, that is good enough. But of course, if you want to be on the other end, where you want to be operating in low and middle income countries, you have to give time. Because if you are a trained neurosurgeon from UK or a trained neurosurgeon from Singapore, you're going to end up in Africa and you're going to tell me I have forgotten how to operate, because you're not going to get the same equipment. You're not going to get the same set of, your team and be able to deliver what you intend to deliver. So I think it's about, if you want to do global neurosurgery where you're sitting in Uganda doing surgeries, you have to accept the fact you might give up your clinical practice to a very great extent. If you think that is not what you're ready for, research, policy making, and education are some of the other aspects you can focus on. And I think that's where you have to decide what works for your heart, and it's not going to be the same for everyone. I think those are my few cents of what I think. Yeah.
Perfect. Thank you. Thank you. That's really insightful. One very short comment, because we are already running out of time. I think,
Can I also,
yeah, Milan.
sorry, I raised the hand. So I also wanted to mention the payments and the point that probably nobody is going to pay you to do exclusively global neurosurgery. That's probably the very, very important point in terms of life of a neurosurgeon, and you will probably have to do it as some additional thing you do in addition to all your surgeries that you are already performing for your life. So I would like to hear your opinion on that, and to know whether there is a possibility that someone who is doing public health for neurosurgery is going to be like, Professor Kip Park is doing like that in Harvard, but he's probably the only person in the world who is exclusively paid to do global neurosurgery. And maybe I even wrong about him.
Prof. Hutchinson, do you
Yes.
want
Yeah.
Yeah.
Yeah, it's been Swati, that was a great talk. I'm conscious of the time. I've got two thoughts. The first is I don't underestimate what you can learn by visiting low middle income countries, and you can learn all sorts of surgery, and you can also learn large volume of high-end surgery, including aneurysm clipping in many parts of the world, which sadly, as we know, is a skill that is being lost in other countries. And secondly, Swati, I think you're right. I mean, it is about sacrifices, but I do still think you can maintain a high-end neurosurgical practice in high-income countries and visit other countries, low middle income countries. But a key, you both of you are absolutely right. It is about delivering local capacity and building local capacity rather than just going in there, doing a few operations and coming out again. So it is about education, training, and research. Yeah.
I think Prof, sorry. No, I was just going to say, Prof, I agree with you. The things that you learn from 2 days in when I went to Moshi is more than I could have learned in few weeks being in Singapore. So yeah, definitely. Yeah.
Yeah, thank you so much. That was a beautiful session, and I really want to thank all of the participants. That was really an eye opener. Please feel free to use the Q&A box to ask more questions, and hopefully some of our panelists will be able to respond to them. I will move on to the next session, where we're going to discuss one of the hottest matters in the whole world at the moment, which is AI and machine learning. Everyone's talking about it and is trying to understand how this can fit our practice. We'll start with Giovanni Raffa, who is one of our, he was the previous chair of our committee, and he's working in Messina. He's a associate professor in neurosurgery there, and he's going to talk to us about the future of simulation training in neurosurgery. Giovanni, thank you very much.
Thank you, Evangelos. Can you hear me and can you see my slides? Yes, perfect. So good morning, good afternoon, and good evening to everyone, since we have people connected from Los Angeles to Sydney. So thank you for being here. I'm really happy to be here today with you with the second edition of a successful event this June too. And we will change now the focus of our lectures because I will talk about the future of training and in particular of simulation in neurosurgery. So let's start with some definition. I hope you know who is the people depicted here in the picture. So training is the action of teaching a person or an animal a particular skill or a type of behavior, while simulation is the imitation of a situation or a process. And we all know how important is simulation in our everyday training, in our long path to become a full neurosurgeon. But of course, training can be really different across different countries. I want to show you this survey that was published 10 years ago that was focused on the different path for neurosurgical training in different European countries. And as you can see here, there are many theoretical and also practical differences across country, at least in Europe, but of course, I'm sure around all the world. And the EANS is highly committed, as Professor Sala showed to us, to try to harmonize the neurosurgical training at least in Europe. And Professor Sala showed to us that ENS is providing every year different courses, hands-on courses, CME accredited courses, during which we have theoretical education, but also hands-on education for training and for simulation to improve our learning curve to become a skilled neurosurgeon. One of these events is the Young Neurosurgeons Meeting. The last one was in Faro, Portugal, 1 month ago, and of course it included many also hands-on session for improving our skills as surgeon, because simulation, that is the repeating of an action several times, is the best way to learn doing something. But of course, in our specific case, so talking about training in neurosurgery, of course, the possibility to repeat our surgical procedures depends on the exposure in UR to surgical procedures. And of course, the exposure can be really different in different centers and can be different also in the same center during a year. So the problem is that once we learn something, there is always, as you can see here, a forgetting curve. So if we want to maintain our skills, we should try to exploit this so-called spaced repetition learning, that is a cognitive phenomenon where learning is significantly more effective and long-lasting when study sessions are spread out over time. So we should try to repeat our procedures, possibly in UR, but eventually even in a cadaver lab or during hands-on courses, just to fill this gap and trying to make our learning curve spinning up and trying to learn something new and maintain our skills over time, despite surgical exposure that can be not so homogeneous. So the constant practice using simulation can be really helpful for our training. This concept is very well established in aviation. Flying pilots are required to perform simulation sessions to keep flying, but in my opinion, we should do the same also during our training program as neurosurgeons. And of course, the ENS is trying to offer different opportunities for performing this simulation session, of course, starting with cadaveric dissection. That is the most important step. The ENS offers, for example, the in cranial and spinal step 1 and 2 courses, which are hands-on courses on cadaveric specimen for performing different surgical procedures from basics 1 to advanced 1. Because of course cadaveric dissection is for sure the best way to understand surgical anatomy, to perform our surgical procedure, and to improve our skills. But there are also some limitations because cadaveric dissection can be expensive. We need a cadaver lab, and usually we have only one cadaveric specimen in front of us. So we have one shot to try to perform our training without wasting our cadaveric specimen. So it's something like a golden ticket. We don't want to waste the opportunity to perform our dissection in the best possible way. But that's the reason why in the last decades there's been the development of modern simulators that are based on different mechanisms. There are simulators for mental training based on virtual reality or augmented reality, where we can learn how to perform a procedure using advanced mixed or virtual reality, or there are also manual training simulators that can be biological models or modern artificial simulators. And using those simulators, we can create a virtuous circle, if you want, because we don't have only one cadaveric specimen available for us, but we can have some physical models. For example, we can have some software for augmented reality or virtual reality simulation, and so we can train, repeat our procedure, learn something, make even mistake, and then we can continue performing our training. We are still in a safe zone because we can also make mistake. We are not in UR. So simulation has a very, very important role today in the training path of all young neurosurgeons. And the modern simulators are usually cheaper than standard cadaver lab. They are very didactic, and they offer also multiple chances, as I show you, to repeat and repeat and repeat the procedure, trying to exploit that space repetition concept that I showed you before. And coming back again to the EANS, one tool that is provided for free to all EANS members is the 3D Atlas of Neurological Surgery. That is an augmented reality atlas that provide reconstruction based on photogrammetry that can be used to simulate the surgical approaches. It has been funded by EANS. It is supported by the EANS, and is for free. And as you can see here, you can easily replicate what you usually perform in a standard cadaver lab. For example, a retro-sig approach, like in this case, in which you can use augmented reality to better understand the relationship between the different anatomical structures. So you can use this kind of simulation while you're at home, relaxed on your couch, and you can repeat it how many ones you want, and you can bring your cadaver lab at home. This is another example. This is fiber dissection, white matter tract dissection on brain, treated using the Klingler technique, in which you can identify different subcortical fascicle, like the arcuate fascicle, the longitudinal fascicle, and so on. You can replicate what you usually perform on a fiber dissection lab. But then there are also the physical model. We started with a bunch of my Italian friends, including Dr. Zoya, of offering some courses using physical models to young Italian neurosurgeons. We started performing these hands-on courses, offering the possibility to young neurosurgeons to perform standard basic cranial approaches to study anatomies on those physical models. Of course, the anatomy is simplified, but is in my opinion, it's a very good way to start learning anatomy, learning how to perform surgical procedure. You can see in the video the clipping of an aneurysm. This is another physical model in which we can use the ultrasonic aspirator for performing white matter dissection and identify the most important subcortical fascicle depicted in different colors here. Then, of course, there are also some even more advanced software that allow for training using mixed reality or virtual reality. And we started in 2022 trying to promote these hands-on courses also during the YNC meetings, providing young neurosurgeons participating to the YNC meetings the opportunity to simulate using advanced and augmented and virtual reality, or performing simple procedure like in these pictures that were taken in Madrid in 2023, performing cranial approaches or the dissection of and resection of a convexity meningioma, or even here you can see again the tumor resection using ultrasonic aspirator in very reliable physical models in which we can use also 5LA fluorescence for tumor resection. Here again, some other picture from the YNC meeting of the last year, performing again 5LA tumor resection under the microscope, or even endoscopic endonasal transphenoidal approaches, or even endoscopic or robotic spine surgery. So during that hands-on courses, all these young neurosurgeons were exposed to different simulations just to improve their skills and just to try to push up their learning curve and make it shorter. This is another example, performing simulation on microvascular sutures and anastomosis. This is the last YNC meeting in Faro, in Portugal, where you can see here different booths with different types of simulation sessions on cranial approaches, on spinal approaches, and so on. But of course, what is the scientific validity of those simulators, especially the physical simulators? The first papers have been recently published, like this one that has been published on Journal Neurosurgery, demonstrating that the use of physical simulators has a positive impact and on the training of young neurosurgeons and can reduce their learning curve. But there is also the possibility to organize some hybrid courses in which theory is followed by the use of physical simulators, and then the same procedure performed on physical simulators are performed on cadaveric specimen. This is a new format that has been invented by my very good friend Cesare Zoia from Italy, in which all young neurosurgeons can replicate the surgical procedure on simulators, trying to understand the surgical anatomy that is simplified on physical simulators, and then move quickly also on the cadaveric specimen, trying to perform the same procedure on the cadaveric specimen, and that can help young neurosurgeons in better understanding the anatomy that they are visualizing on the cadaveric specimen, because sometimes it's not so easy to identify the anatomical relationship, especially if the specimen is not well prepared. So this is just an example of course that has been organized in Italy by my friend Cesare. And there are hybrid courses. This is a completely novelty in the landscape of training courses around the world. And even the hybrid courses have been evaluated. You can see here this study that is very recent, just published August 2026, so ahead of print, in which the author compared the efficacy of training only on cadaveric specimen or as it happens on hybrid course, first on physical simulators and then on cadaveric specimens. And again, this paper demonstrates that the hybrid training that integrates simulation and body donor dissection enhances the anatomical learning and technical skill development for young neurosurgeons. So the performance of simulation session on physical simulators before performing cadaveric dissection improve the velocity of the learning curve of our young neurosurgeons. And now I want to end my talk talking about future perspective, because using physical simulators is also possible to imagine to apply some sensors that can use some metrics to measure the skills of the young neurosurgeons. All those data can be used to create some AI models that can be also used for AI coaching of young neurosurgeons, trying to correct them, trying to make suggestions to improve their surgical skills, and then could also lead to the creation of some skill certification that can help young neurosurgeons in completing their training path. So using this kind of models, we can certificate that the single young neurosurgeon has acquired a specific surgical skill at the end of his training program. And then this is another perspective, very interesting, in which we can try to improve the learning curve of our young neurosurgeon using simulators and even creating a patient's avatar using augmented reality, virtual reality to exercise just before entering in UR, trying to perform our surgical procedure on this virtual reality or mixed reality avatar, just to improve not only our surgical skills, but especially to try to improve our surgical procedures that could even result in a better outcome for our patient. So in conclusion, I will say that simulation-based training course, and in particular the hybrid courses, are a really valuable tool for shortening the learning curve of our young neurosurgeons and represent a first fundamental step for approaching cadaveric dissection. Performing simulation on physical model can even improve your experience during cadaveric dissection, give you the opportunity to fail in an easier way as compared to just performing only cadaveric dissection. But there is space for sure for future models based on skills metrics acquired during simulation that can improve our training, and trying to also harmonize it throughout countries, creating some also surgical skills certification that are an objective measurement of your skills, of the skills that you acquired during your simulation session. And probably in the next decade, we will also assist to the realization of virtual reality models that can be used every day and can have an impact not only on your surgical skills, but also on patients' outcome. In conclusion, last slides, if you are interested in the training opportunities provided by the EANS, my strong suggestion is to become an individual member today and stay tuned with the EANS training opportunity, starting from becoming a member of the EANS Young Neurosurgeons Network and joining us in our hands-on courses, and of course in our main event, Save the Day, the next EANS Congress in Hamburg at the end of September, beginning of October. Thank you so much.
Thank you. Thank you very much, Giovanni. I'm aware that we need to release you because we've already kept you a bit longer than we should. If anyone has any questions, please put them in the Q&A box and we'll try to respond. And I will forward any of the questions that we cannot answer to Giovanni and try to get answers for you. Thank you so much. Moving on to the next speaker, it's my distinct pleasure to introduce Emal Lesha. He's a trainee who currently works in Memphis in US, and he is one of the members of the CNS Resident Committee, and he really was instrumental in making this meeting a reality. And he's going to talk to us about applications of the artificial intelligence in neurosurgical training. Thank you, Mark.
Thank you, everyone. Thank you, Evangelos, Akiba, Milan, and the rest of the EANS team, as well as my CNS Resident Committee folks for putting this together. I'll be talking to you briefly about AI in neurosurgery residency training coming from a trainee. As Evangelos said, I'm a PGY7, seventh year neurosurgery resident, University of Tennessee, and Sam's Murphy Clinic in Memphis, Tennessee. Let me go to the next slide. So, not to belabor the point, but AI has imploded within the field of neurosurgery over the recent decade. There is nothing that you can do or talk to in neurosurgery that does not mention the words artificial intelligence, machine learning, deep learning, artificial neural networks, and the number of publications and indications has significantly increased. When you talk about anything but diagnosis, management, and even surgical innovation. This is a paper from 2022 that shows the current trends, that essentially shows the number of publications within AI and neurosurgery. And as you can see, the field was quiet, and then from 2018 up, it just going upwards. And it's essentially in every field in neurosurgery: tumor, spine, epilepsy, vascular, functional, and more. However, when you look at the actual publications and the work out there, the majority of it is focusing on prediction models and diagnosis. And a very small part of it actually focuses on surgical training and neurosurgical education. So as a trainee, what are the premises of AI? Number one is understanding AI and its capabilities. And number two is actually taking advantage of the technology. And I'm going to talk about these two things in a reverse order. So when you think about AI and surgical training, I think we have to take a step back at simulation training. And Dr. Rafa gave an excellent talk focused on this. But simulation training has been around for a very, very long time, decades ago. Aviation, military, sports. And in medicine, especially in surgical training, there's been many, many publications within general surgery, orthopedics, obstetrics, gynecology, and neurosurgery, essentially showing that trainees that undergo virtual reality or simulation trainings do better in the OR than residents and trainees that do not. So when we look at AI and within neurosurgery from an education perspective, there are kind of two categories of it. One is actual neurosurgical education, board exam preparation. In the US and as in the rest of the world, as a trainee, you have to take neurosurgery written boards. And there were a few studies that were testing how did ChatGPT do with answering questions that we take on our neurosurgery written boards. And this was an earlier study a few years ago testing the initial version of ChatGPT, 50 questions from the neurosurgery written boards, and compared it to 10 junior residents. And ChatGPT fell right in the middle of it. I mean, it essentially did average. And this was the first model. They did a subsequent study with a second model of ChatGPT, GPT-4, and tested it, versus these SANS questions. And for those that don't know, the SANS is a library of questions prepared by the Congress of Neurological Surgeons that neurosurgical trainees here in the US use to prepare for the written boards. So they tested 643 questions against GPT-4, and it was able to answer them 76.6% correct. And when you look at what the mean SANS user, score is, and these are essentially a group of probably hundreds of neurosurgery residents, over the years, their mean score is 69%. So GPT is already doing better than us in answering questions. And then the other aspect of it is actual technical skills. There's been a lot of studies looking at essentially coupling simulation training with machine learning and deep learning, and focusing on things like microsuturing, arachnoid dissection, as well as procedure-based training. So I'm going to give just a couple of examples here from the literature. So this was a study that was done by the Neurosurgery and Orthopedics Department at McGill University in Canada, where they simulated an L3 hemilaminectomy. And they had two groups. They had the senior participants, which were essentially neurosurgery consultants, attendings, fellows, and senior residents, as comparing them to junior residents and medical students. And they picked a bunch of metrics. Again, backward selection algorithm. It's a modality that can be used where machine learning essentially says, okay, from all these metrics, these metrics are the ones that actually matter based on the data. And the findings are very interesting. I think the most the most striking finding is that the algorithm was able to determine with 97% accuracy, based on the performance of the folks that went through the training, who would be classified as a senior participant and who can be classified as a junior participant. So and it was only able to. He only missed one person, one junior resident, because they actually did really well. They did the procedure so well that the algorithm classified them in the senior group. But then on the other side of it, what machine learning and coupled with simulation can help with is it can tell us things that we know intuitively in the OR. How a senior resident should perform, and how staff should do a laminectomy, but we don't really talk about it as much. So for example, senior participants, they applied less force on the dura when drilling. They spend more time using both hands. They showed slower deceleration and acceleration on the drill. So again, highlighting the importance of how machine learning can help us train us better. And this was another study looking at subpial brain tumor resection. They essentially took 70 medical students, and they gave each one 5 practice resections. They had a feedback session, and then they had one realistic tumor resection afterwards. And the feedback was either AI or it was an expert, which was essentially a neurosurgical trainee or an attending. And there was no significant difference between AI and the expert feedback groups. So that is one important thing to know. But I think the most important striking finding from this is that the experts spent 53 hours giving feedback versus AI was able to do that in probably 30 seconds to a minute. So again, highlighting the importance of how AI can help us train residents, medical students better. So with this in mind, now we take a step back and we look at AI education for neurosurgical residents. Any literature, any article that you read within neurosurgery and AI, you will see all of these terms mentioned. Generative AI, artificial neural network, random forest algorithm, decision trees, supervised and unsupervised learning, support vector machine, and more. And we don't have the time today, but if I did at the time, I would have polled the group today and essentially asked everyone, do you actually understand what most of these mean? Because when I talk to my colleagues, even some of my attendings and medical students, most of them say that they actually don't. And what I want to highlight is that understanding artificial intelligence actually requires significant statistical and computational knowledge. And just to give you an example, this is a very simplified chart of what an artificial neural network is supposed to be. So, so the question becomes, should neurosurgery residents obtain some basic training on the principles of these technologies? And to answer that question, I have started doing this study surveying neurosurgery trainees across the US. This is just a very preliminary data. I've surveyed 50 residents from 16 training programs so far, a very good mix of junior residents and senior residents and some fellows, and asking them very simple questions. Do you understand the basic technologies behind AI? Most of them do not. What is your level of understanding of artificial intelligence? 72% said beginner. Are you comfortable reviewing AI-based literature? And most of them said no. Should AI be part of? Do you use AI as part of your neurosurgical education and training? Most of them said yes, which is not shocking at all. But then what are some barriers to actually utilizing AI-based tools? And most of them say lack of training. And we asked the residents, do you think AI can be used to enhance your neurosurgical training? And of course, most of them said yes. And I think this is important because when you also ask the residents, does your program provide any AI related training? Essentially all of them said no. So the lessons from this is, AI can be valuable in enhancing surgical training and education. Can we make the training process more efficient? How should we integrate simulation with in-person training? And should we all learn more about AI? And I think the answer to this is very simple: is yes, we should. I understand that in most of the world, to become to go into medicine, you go from high school into medicine, and then you go into neurosurgery, whatever specialty. In the US, it works a little bit different. You have to do college first, and then you get into medical school, and then you go into whatever specialty you want. And if you look at students that get into medical school, a lot of them actually, they do not even have a basic science background. Some of them study music, they study sociology. Some people study law. So the point I'm trying to make is people are coming from all different backgrounds. And in order to put everyone on the same page, I believe it is important to provide some AI training during residency, considering that this is becoming a big part of our practice. And to finish my talk, I'm going to talk a little bit about the CNS Resident Committee. So it's been going on for several years, but over the past, I would say 3 to 4 years, it has increased quite significantly. This is a picture from a meeting that we had about 2 years ago, and this was a picture from last year. So just year to year, we have grown quite significantly. We do our meetings on Zoom for the most part, and we meet once a year in person at our annual CNS meeting. We do have some international members, and we do have yearly ongoing applications, but in order to be eligible for it, you do have to be a member of the CNS. So I just wanted to put that in there, keep us in mind. The CNS itself does provide some courses and training for artificial intelligence and innovation, keeping in mind that training, that this is becoming a big part of our practice. So there is an artificial intelligence and neurosurgery course. We have a scholarship in data science. And then we also have the CNS Innovation Institute, which has been which is essentially starting this year for the first time, and this is our second conference called the Neuro Innovate. So keep that in mind. If you have any questions or concerns, you can reach out to any of us from the CNS and the CNS Resident Committee. I wanted to thank everyone for putting this together and for a great webinar so far. So thank you so much.
Thank you. Thank you very much, Amal. And yeah, I think the point you made that AI and the point that Giovanni made earlier about simulations that are truly transforming the training process is really important. And of course, as everything is a bit, it's a new tool. So all of these are new tools, and they need to be slowly implemented or appropriately implemented in our day-to-day, in our progress. But I think that this is a very important point, that they are a key point in transforming the training process. Thank you very much. I don't know if there are any other questions from the panel for Amal. Otherwise, Giovanni, are you there? I believe you wanted to introduce Professor Dieva.
Yes. Thank you, Evangelos. It's a pleasure for me to introduce the next speaker, who is Professor Antonio Dieva. He is a professor of neurosurgery at the Macquarie University in Sydney, Australia. He was a young neurosurgeon trained all over the world, from Europe, USA, Canada, then Asia, and now he's working in Sydney. And he has the merit of running the computational neurosurgery lab at his institution, and he also established the first computational neurosurgery fellowship in the world. So it's a pleasure for me to leave him the floor. Please, Antonio.
Giovanni, thank you so much for the kind presentation, and thanks to everyone. So you should be able to see my slides. So I'm talking about this new field, and the question here is what computational neurosurgery is and how we can deal with this kind of new subspecialty. These are my disclosures, and you know that in neurosurgery you have to learn many different things, and you have to decide what you want to subspecialize. So what about computational neurosurgery? Well, the spoiler here is that this is not just a subspecialty itself, but this is a translational field that you can use in all these subfields. And I will just bring some examples here. So let's start with what, why, and how. First definition. This is a definition that I gave many years ago, and we published a couple years ago in our book. Computational neurosurgery is a novel translational field where computational modeling and AI are used to improve diagnosis, treatment, and prognosis of a patient affected by diseases of neurosurgical relevance. So I would like to emphasize that this is not just AI. This is a computational modeling in general as a large umbrella. This is the old definition. In February, we met in Sydney for the first World Conference of Computational Neurosurgery, and we created even a task force in which we gave a new definition. And this is a little bit more comprehensive. We put other things in, including neurotechnology. And the aims are still including diagnosis, risk stratification, screening, clinical decision support, surgical planning, intraoperative support, postoperative management. But we are adding also, as emphasized in the previous lecture, the research, the education, and the training, because this is how the landscape is extending nowadays. So everyone talks about AI, but let's be honest, my journey, and because many people they ask me how and why I started this, my journey started with a pattern analysis, which is something in machine learning. But I would like just to let you understand how this pathway and this journey can be done from a student level to a resident and a specialist. So, for example, when I was training, my main specialty and interest was in pituitary endoscopic surgery. And I was trying to understand if the vascularization of the pituitary tumor and the gland could be characterized and quantified by means of a computational modeling. So here we have immunohistochemistry for a normal gland and a pituitary tumor. We know that there are less vessels in the tumor, but the way we quantify that was very, very heterogeneous in that time. So I just found from my understanding in maths, the fractal geometry was a very, very good way to quantify the geometrical complexity of vessels. And this is a very old paper that I published more than 20 years ago, in which we were trying to understand how the pattern of vascularization could be quantified and characterized according to the pathology. So I introduced the fractal dimension of the macrovascular tumor, and after that, I realized that this was a way to extract features in order to recognize patterns. So the pattern of the normal gland versus the pattern of the tumor, for example. And this was also the way I started also my PhD. Another way to see the computational neurosurgery is also the decision trees. Remember that in neurosurgery or in medicine in general, we love really this kind of decision trees. So this is just an example of what do we think and we do with the management of a large vestibular schwannoma grade 3 and 4. So not by chance, even in machine learning, there are the decision tree learning, which are data mining supervised learning techniques, which basically they put together a set of observations in order to have a predictive modeling to try to understand if we go towards the left or the right side of the branch of the arborization of the decision tree itself. So computational neuro-oncology is one of the examples that we can apply this for who does neuro-oncology like myself. We have two domains here. We have the neuroimaging domains based on MRI or nuclear medicine, and we have the pathology. Now, everything can be digitalized nowadays, and we know that the imaging becomes a computational neuroimaging field, and the pathology becomes a computational neuropathology field. So some examples. This comes from my PhD, so more than 15 years ago, but it was just to show that the macrovascularization of glioma can be characterized by means of some fractal parameters or some support vector machine. And the computer, without knowing anything about pathology, was able to put some kind of order in this tumor. And not by chance, these were glioma grade 2 and 3 and 4. So in a nutshell, it means that the computer is able to recognize features in order to give us some diagnostic power. This is digital pathology. We can go to the digital neuroimaging. This was the first demonstration that 7 Tesla MRI is very good to see some intratumoral features. And this can be characterized by the same model. So I use the same model as a kind of a Rosetta Stone to jump between different subfields. So when I use that kind of model, I was able to show that it's very useful to quantify patterns in the same patients in the longitudinal way, for example, to see how the tumor changes over time, or different patients having glioma to characterize what kind of a grade they have, or even different kind of tumors. So the machine was still able to tell us if these patterns are recognizable in terms of diagnostics, telling us if this is a glioma, metastasis, or lymphoma, or so on. So this is how we use the pattern analysis. In a nutshell, fractal patterns and machine learning could be used in digital pathology and in neuroimaging for many, many applications. I gave you some examples in pathology, but this can be done also in arteriovenous malformation. And we also published a lot on time series analysis, like EEG, magnetoencephalography, or intracranial pressure. If you're interested anyway, we put together a couple of books on the fractal geometry application in the brain. So what about AI? So I already used machine learning in these models 20 years ago for clustering of these features. And nowadays we use a lot of deep learning, which went towards the generative AI. And nowadays we are already in the new era of the agentic AI. So brain tumors are a very exemplary computer vision based workflow. First of all, because we have the MRI before the operation, and we can use deep learning for now automatic segmentation of the edges, not just of the tumor, but all the features related to the tumor, the necrotic area, the edema, for example. And why we do that is because not just for volumetric analysis, but because we can extract features from this region of interest by means of radiomics, which is a kind of a mathematical modeling, extracting a computational and inferring a computational metrics, which can be used for diagnostics and even for prognostications. So this is the pipeline that we built up in my lab almost 10 years ago. Every patient coming to my clinic, he undergoes this pipeline. So we put the MRI in this pipeline, there is the segmentation, and we try to predict features in terms of diagnostics, differential diagnosis, and other kind of feature prediction. What about pathology? When we have the tumor out, we have to wait days or weeks that pathology tells us what the tumor is, for example. But if we apply the principles of radiomics to the digital pathology, we have what we call pathomics. And it's the same concept. We're just checking some metrics and infer some parameters at a pixel level in the digital pathology. So deep learning can be used for diagnostic and prognostication as well. And this is just one example, for example. You can see many gliomas. We know that these are gliomas, but we cannot know if, for example, they harbor the IDH mutation. Why? Because you need immunohistochemistry or genetic sequencing. So the question I had 7 years ago was, can we use just these simple images before doing the genetic testing to predict the genetic status? And so we built up a model, a ResNet 50 models, in which we had a very, very high accuracy to predict just by this that the IDH mutation was there or not. So this saves time and money because we can know this in real time. The problem at that time was that the data set was pretty small. So we had also the idea to generate new synthetic images by means of what is nowadays a very, very normal thing used nowadays, which is the generation of images. So this is a model that we built 7 years ago to generate a synthetic glioma. And by doing that, generating a higher data set of glioma, we were able to increase and skyrocket the accuracy of the training model. One of the problems we realized was pathologists are not really tricked by the fact that the staining are very, very heterogeneous, but the machine is tricked by that. So we even introduced a new generative model in which all these heterogeneous stainings can become very, very homogeneous. So we use the generative AI to synthesize the same images, but with a very, very balanced staining, which does not trick the computer. And by doing that, nowadays we are able to predict the genetic status of the IDH mutation on MRI and on digital pathology with almost an accuracy of 90-80%, which means that basically we are reaching almost the gold standard of the pathologist, not to replace them, but to have an implementation of the diagnostics. So let's go to how we implement all this in theater. A typical example of a tumor, most likely low-grade glioma in the right frontal lobe, most likely in the front, in the supplementary motor area, which is in the non-dominant part. We do a deep learning model before surgery. The radiomics tells me that there are some features which go towards a specific diagnosis that I will tell you later on. I always use connectomics. This gives me the information about the networks, and you have to know that also this is based on machine learning. And connectomics is used to let me tailor maximal or eventually supramarginal resection in some tumors. In this case, for example, I was able to predict that I could not have done a supramaximal, but I could have achieved a maximal resection, which is this. So when we had the pathology back, this was the final diagnosis. But if you go to see what we predicted at the beginning, basically we know the machine told us that most likely is a tumor, most likely is a glioma, and very, very likely is an astrocytoma, with a low chance that it was oligodendroglioma. And there was also even a radiogenomic prediction. So if you see, there is a very nice correspondence with what we had after surgery with what we knew before surgery or during surgery, because we send even the frozen section to the model. So this means that in the future, we are able to predict more and more things in real time in much, much quicker fashion. And this, of course, could benefit our workflow. How we bring all this information in theater? There are other applications for AI. So this is one of the typical operations I do, microscope, endoscope assisted in the skull base. And years and years ago, I was already dreaming to have a deep learning model telling me all the anatomical structures. So before we go to such complexity from the anatomical point of view, we started with something a little bit simpler. I used some collaboration with the ENT. They do a lot of middle ear surgery. And the idea was doing a labeling of 3 structures, just the stapes, the chorda tympani, and the facial nerve, and to see if in real time we can have an automatic segmentation of the structures. And here we go. This is an endoscope in the ear telling us exactly what is what. Now, extracting this simple model, which was a simple unit, to something more complex that nowadays we do with the transformer, we're basically able to do something like this, in which there is an automatic labeling of all the anatomical structures in real time. Of course, these are probabilistics. That doesn't tell you what is exactly, but it tells you that the most likely this is the optic nerve, for example. We have other applications. We can shine some light and laser on the tumor, and this will tell us basically what is what. We can do with the Raman spectroscopy, or we have experience also with hyperspectral imaging. And of course, deep learning is used to extract features and telling us the diagnosis. Prognostication is very bad nowadays. We published this years ago. We know that the prognostication from MRIs is still pretty bad. We are bad. AI is bad. But imagine that one day we can skyrocket the prediction of the prognosis to 90, 95%, or even 100%. There will be a lot of ethical dilemma, how we give this information to patient and family. So that's the reason why we put also some ethical principles. We wrote the Declaration of Computational Surgery, which later on became the Declaration of Sydney that we declared and pledged at the Computational Surgery Conference in Sydney. And I would like to endorse you to basically go to this web page, read the 15 articles of the declaration, and if you agree, you can even sign it electronically, because we are trying to make it more and more viral, how AI can be ethical and responsible in the neurosurgical applications. So MDT, every one of you, like me, basically most likely brings the patient to the MDT before doing decision making towards surgery. But if we implement the AI, the MDT, we know that there are some barriers. MDT is good, but it's not perfect. So we had the idea to bring this little guy, which is the AI, to the table with us in order to implement and to extend our decision making. And this is the real AI of the future, not seen as an artificial intelligence, but as an augmented intelligence in order to increase and augment our decision making. And this can be brought also to MDT as well. And that's the article in The Lancet where I wrote that machines will not replace physicians, but physicians using AI will soon replace those not using it. I wrote this 7 years ago, but actually it's happening in many, many places. So in conclusion, this was just an example of how AI can be used in neuro-oncology, but I haven't spoken about a lot of other things we do, because we can use all the omics like transcriptomics, genomics, and using AI as an orchestrator of all these huge data set. And of course, there is a robotic simulation and things like that. To learn computational surgery would be very good that you learn the maths behind that. But there are so many cross-translational fields generated by the field that, of course, you cannot be expert of everything. So that's the reason why, first of all, I created a lab which is extremely translational. The computational neurosurgery lab, we have engineers, mathematicians, statisticians, and ethicists working together for the computational neurosurgery field. But we have even a fellowship, because now it's 4 years that some neurosurgeons come to my lab. They learn the basics, they learn the foundations from the mathematical and engineer point of view, and they learn an application in neurosurgery itself. So this is year 4 of the computational neurosurgery, and in 2027 we'll select the new one for 2028. So in a nutshell, learn AI, don't fear it, and it's time to use it properly. And I would like to thank you for your time. And I'm ready for questions, if any.
Thank you very much. That was truly how AI can and all of these computational models can enter our life, or have entered our lives already professionally and on day-to-day life, to be fair, and how they can transform our practice. I do believe there is one question in the chat for you. It's I will leave that for the chat for you to answer.
I have a quick question, if that's
Yeah.
okay. So, Professor, that was an incredible talk. With regards to AI diagnoses, and all of this is happening very fast. And I appreciate that it's sort of become a big thing in some parts of the world. The question is, in terms of the legal implications of using this for diagnosis, for prognosis, we're not at a stage yet where we can safely do that without potentially be open to criticism. So, do you know how this is being looked at from a legal perspective? Is there work being done to see what would or would not constitute a legal breach with regards to what we're doing?
Yes, no, it's a very good question. And if you go to the webpage of the Declaration of Sydney, you will see that basically this is already a work in progress. Some of the people of the task force are lawyers with expertise in neuro rights and the neuro laws. The reason of that is because, first of all, we have the problem with explainable AI. Many things that AI does is not really understandable from the diagnostic point of view. And we are trying to understand how this can be made more explainable. And number two, if there are problems, there is the problem of the root cause analysis. Where does it go back? So is the responsibility going back to the machine, to the operators, to the software maker, or the neurosurgeon? Of course, as clinicians, we are always responsible of the tools we use. But there are many, many implications and ramifications that we're working on with the lawyers and the philosophers and the ethicists. And that's the reason exactly why we put the Declaration of Sydney. There are many, many items just talking about how we can make these better in the future in terms of also from the legal point of view and the ethical point of view. And there is a lot of discussion, especially for the brain-computer interface and neuroaugmentation, because there is where the topic becomes really hot. AI can be used for doing a kind of a cognitive augmentation. We are going towards that, and of course there are huge problems from the diagnostic, clinical, legal, and ethical point of view. But to answer your question, yes, in diagnostics we are already working from the legal point of view as well.
That is a really important point about the applicability of all of these technologies when it comes to clinical practice. Thank you. Thank you again so much. If there are no other questions, I will pass on to Emal for the next session that is mostly from that has speakers from our colleagues at the CNS. And Emal can do the introductions, and we're looking forward to their talks on upcoming technologies in various aspects of modern neurosurgery.
Thank you, Evangelos. So this next section, as Evangelos mentioned, is going to focus on upcoming technologies in neurosurgery. We have a good mix of talks focus on spine, functional neurosurgery, as well as cranial vascular. We'll start first with Dr. Julie Chan. Dr. Julie Chan is an assistant professor in the Department of Neurosurgery at the University of Florida. Her practice focuses on complex spine surgery, minimal invasive spine surgery, and spine trauma. She's also in the executive committee of the Congress of Neurological Surgeons. She's technically my boss, Dr. Chen. Her talk today will focus on minimal invasive lateral interbody fusion, which I think is a very upcoming technology in spine. Thank you for being here with us today.
Thanks, Amal, and thanks, Evangelos, and of course the entire EANS for giving me this opportunity to talk. So as Amal mentioned, I'll be talking about lateral lumbar interbody fusion, which I certainly think is a fantastic approach to the spine. So just to go, to start with our background, we know degenerative spine disease is a huge burden across the world, right? 266 million people actually annually experience degenerative spine disease. It does not discriminate. Almost certainly every single one of us is going to experience degenerative spine disease at some point in our lifetime. And specifically, even 5.5% of individuals suffer from disc degeneration, right? Well, why do we care? Disc degeneration evolves often into degenerative spondylolisthesis, which affects 39 million people across the world annually. And of course, as our population continues to age, that becomes even more prevalent every year. So what is spinal stenosis? I think most of us know this, but just as a reminder, spinal stenosis, of course, narrowing of the canal. Just a little schematic here, right? What happens? The disc degenerates, things start to slip forward. Not only do we now have narrowing of the canal from that degenerative disc disease, but that slip forward and that unroofing of the disc. A representative example down here being at this L3-4 site. You can see that the disc certainly is desiccated, right? It's certainly thinner compared to L4-5. You have this unroofing of the disc, and subsequently on this third panel here, narrowing of the spinal canal compared to, say, at another level or at the level of the pedicle, where you see nice white CSF and good cushion. So really, I'd say this is the most common disease, right, that we're seeing and treating that can lead to clinical issues, right? What's the clinical issue? Well, pain for one, right? This can also compress the foramen where the nerves are exiting, neurogenic claudication, which leads to worldwide disability, loss of productivity, right? People can't go to work. And of course, the worst thing being neurologic compromise, right? If this progresses far enough, patients can actually develop neurological compromise meaning paralysis, loss of bowel and bladder. Less common, but certainly if we don't approach this sooner than later, that can be an issue. So how do we do this? Of course, we always start non-operatively. Anything we can do to avoid a spine surgery, I think, is paramount. But ultimately, those non-operative options or techniques may just not be enough, right? Patients may exhaust them and they're no longer effective. I think obviously the most straightforward and less invasive approach to this is going to be decompression, right? Your laminectomy, of course, but in some cases that may not be enough. Decompression may not only be enough, but it can destabilize the spine, especially if a patient already has a slip, a mobile spondylolisthesis or even spondylolysis. So they really will necessitate a fusion. I think arthroplasty has been in favor as well. Lumbar arthroplasty, not as much, given the data that wasn't so favorable, but certainly in a younger patient who doesn't have an active slip, this can reduce the chance of adjacent segment disease, meaning more disease up and down the spine as we have that fused level exerting more pressure. So how did fusion evolve, right? I mean, this is the main point of the talk, fusion of the spine with the approach being lateral. So first, right, we have our posterolateral fusion. We found that once we decompress the spine, we can certainly decorticate your facet joints here, as well as fuse across your transverse process, which works fantastically, and it's great because it doesn't involve any instrumentation, reduced operative time, and less chance of a nidus for infection with your hardware. We evolved then to posterior instrumented fusion, pedicle screws, really getting a lot of purchase in the bone, especially when we get to our longer constructs where there may be more pressure on the spine, more chance for a kyphotic deformity over time. And then, of course, later on, we found that interbody fusion is a good option where we place anterior support, the anterior column, especially when our axis of rotation, we have a lot of force on that vertebral body, right? So if we can get more support with the anterior column, we found that works really well. You can do that standalone a lot of times, especially something like this with a big graft. And then we found later on, right, that 360, meaning front and back, supporting all those columns is really the most, not only supportive for the spine, but therefore highest chance of achieving fusion, decreasing that motion. And I think that makes sense, right? You have these cages in the front, and then of course your posterior instrumented fusion. So putting all of that together. What are the approaches, right, that we can do this? You can see this big footprint here. What are the approaches? Historically, right, we did a PLIF, posterior lateral interbody fusion, pop off the entire posterior spinous process, lamina, take down the facets, which can give you nice, really, really nice access. But of course, we're retracting the thecal sac. Other options that evolved are going to be your transforaminal approach. And so you will have to, of course, retract the nerve root for this. But again, we are not taking necessarily down all of the posterior elements. And then, I think what evolved over time too is we realized these graft sizes can't be as big, certainly, right? And I'll skip to the next slide here. So, but ALIF is another approach, and then coming lateral, which is the one I'm going to talk about in more detail soon. Other names you may see for this are proprietary, the DLIF being direct lateral interbody fusion, XLIF being extreme lateral interbody fusion. They all mean the same thing. All of these, I would say, would be through trans psoas, but you can also come anterior to psoas, which is going to be your OLIF. So pros and cons, right? I think we all know spine is variable. What is the best approach is going to really determine what's not only based on the patient, but what's best in that surgeon's hands. What does that patient population suggest in terms of what is the best approach? In terms of a posterior approach, I think obviously it's the most tried and true. It is a workhorse for most of us, whether it's a TLIF or a PLIF. You don't need an access surgeon, right? You're already going posterior. You can decorticate the facets. You're putting in your screws posteriorly as well. So that in itself is decreased operative time potentially as well, because everything's in the same place. In terms of complications, as opposed to an ALIF, right? You're coming anterior. You have large vessels. You also need you have large vessels in the way. So interior approaches, they are positive because they can have a larger surface area. We decrease tissue disruption, but we can have concerns about other complications. just to harp on why really the lateral interbody fusion has gained such popularity is we know that the ALIF really provides a very, very nice large surface area for fusion surface, right? If we look over here, whether we have a single bullet cage TLIF or even a banana cage, or even double cliff cages, it certainly does not cover the entire area. It doesn't sit entirely on the apophyseal ring as an ALIF does. So of course the ALIF is the biggest graph you can get. Why do we care? Two reasons: surface area for fusion, as well as decreased risk of subsidence, right? That cage pistoning up or down into the vertebral body, which certainly becomes a concern with our aging population as patients tend to develop osteoporosis. So lateral, which I'm talking about today, it kind of, in my opinion, meets the best of both of those worlds in the sense that you do get a really, really nice footprint, right? But you don't have potentially the potential complications of going anterior, right? Not only that, but for a lot of us, I know, especially particularly at institutions in the United States, while some of us historically have done the access on our own, certainly a vascular surgeon is going to be much more well versed in that arena. Not only that, but if there was a complication, certainly it would be very important to have them available. And certainly it opens yourself up to other medical legal risks if you are the one performing it yourself. But purely from an anatomical standpoint, certainly less risk if we're coming, or different risk, I'd say, if we're coming in laterally. The biggest, I'd say, concern when you're coming in laterally is going to be your lumbar plexus, right? And we'll go over that in a little bit. But I really think the keys to success when you're planning your lateral is probably, I'd say, true for any spinal surgery, but particularly the things I think about is it's really your preoperative planning is incredibly key. I'd say your potential bailout options are less. It's forcing you to maybe go into another position. So you really need to know your anatomy, study that well with the patient, because we're not just studying posterior anatomy anymore, right? We're looking at the structures that are lateral. Where is the kidney? Has the patient had any prior surgeries before? Positioning is super important as well, and we'll go over that in a bit. Retractor time, posteriorly, where everything's splayed open, but here, if you are going transpsoas, and even if you're going anterior, really got to consider that retraction time or pressure on the psoas where the lumbar plexus is. So again, basics things, right? Where's your psoas? How do the ribs look? Where is the pelvis when you're thinking about a lateral approach? So just a reminder on your anatomy, right? Your lumbar plexus from L1 and inferiorly, but more importantly, we're thinking about lateral, right? We're approaching this laterally. I'd say 3-4 is probably the most common level that people approach because of where your lumbar plexus lies, right? It's going to lie more posterior, the more cranial you are, and of course it's sweeping forward anteriorly as you get to those lower levels, L4, L5, particularly. You can see it comes and encroaches on more of the center of the vertebral body. So, what does that look like? I mean, I think the fastest thing that you look at is you can automatically just look at a quick radiograph, look at where your ribs are, right? How far, caudally are they sweeping down? Are you, in this case, you have, I think, a really good access to L3-4. Doing a lateral L4-5 might be challenging, right? You certainly have a crest in the way here. And then when you want to look at your MRI as well, right? So this is that example I showed before of you have this L3-4 degenerative disc disease, this anterior slip here, the spondylolisthesis with the central canal stenosis. Now you can see if we take this corridor, lateral corridor toward the L3-4 disc space, you can see how the lumbar plexus is posterior to you. Okay, so you have nice access, as opposed to, say, if you were at a lower level, you get what we kind of call this Mickey Mouse kind of picture, right? Mickey Mouse, like I live in Orlando, I've lived in LA, I love the mouse, but not great for lumbar interbody fusion. You can see you'll just clip that lumbar plexus right there. Positioning, I mentioned, super important as well. There are two options you have. Actually, really, I guess 3 in a sense, but lateral is your first option. Head here, obviously, bottom down here, a true lateral positioning. I think the advantage of this is in terms of like thinking about your anatomy, it's more straightforward. However, then you do require the added time of then flipping the patient prone, which is really where the single position prone, as opposed to single position lateral, you certainly can place your posterior screws this way, but single position prone is nice. You're already in that prone position that you're familiar with, particularly for if you were to go posterior as well, either for your screws or for your bailout. I think the challenge for many people of doing a single position prone for a lateral is fighting that gravity to keep your graft posterior and not slip anterior into things that we typically don't like to get into as neurosurgeons, right? Just a couple more graphics for approach for those of you who aren't as familiar with it. This graphic again, coming down laterally through the psoas, and posterior the kidney, and feeling here, and then here, this is our one version of a retractor that's going to be diving deep down laterally. The nice thing, again, I didn't mention about lateral, but the abdominal contents do fall away from you, which is a nice option as well for some of our larger patients, which certainly we are not strangers to as patients have trouble ambulating. Just another intraoperative example of what this looks like when the patient is in that lateral position. This would be your graft here. This patient had another surgery below, but this is showing the insertion of your graft. Here's a representative example of when you get that graft in there, like you can see that really, really nice contact going all the way across for your lateral inner body. It does look like there is some very mild gapping here, but you're getting nice end plate contact on the lateral edges. The other thing you can see is not only is a lateral interbody good for increasing height, but you can certainly correct. So you can get increased height, right, from that degenerative disc, opening up the foramen, but you also get reduction of that spondylolisthesis. In terms of fixation, to really bolster this, what are you looking at? Well, there's a couple options, right? You can do your traditional posterior screws here. Perk screws is typically what I favor for this. Your other option is a lateral plate and screws, right? So here, the plate essentially attaches to the end of the lateral interbody, and then you have a screw that goes cranial and caudal into the bones above and below. You can see in this case, I actually did a standalone at essentially adjacent segment disease case where this patient already had a prior fusion, had adjacent segment disease at the level above, and instead of having to go posteriorly and open up all of that prior hardware and disrupt the posterior musculature, I was able to just put a plate on laterally. Just more postoperative radiographic examples of that cage settling nicely. That was actually that same cage you saw before where it appeared there was like a little bit of gapping, but it settled really, really nicely into good end plate contact here. And again, you can see how, I think you can see the outline of the vertebral body here, but really, really great footprint to reduce the chance of subsidence and increase your chance of fusion. Where are we really going with this? I'm sure, a lot of you have kind of seen these patient-specific graphs, right? And that's I think the other great thing about these is while it can be done with T-lifts as well, while you have this really big footprint in a lateral patient or in a patient and you're doing a lateral approach, you can do asymmetric graphs, right? You can see on one side, it is definitely much higher as opposed to the other. This can really help some of your corrections, especially when you have a patient that has already a prior long construct, or even a patient who you're trying to correct deformity without kicking them over one way or the other when you're not correcting their entire spine. So just to put it all together, I think lateral interbody fusion is a fantastic option. All of them are good options for different reasons. I do favor the lateral if I can. You have the ability to reduce your posterior tissue disruption, right? Those paraspinous muscles are super important for, one, it's painful if you go through them, not just for you as a surgeon, but for the patient as well, right? And that posterior muscular chain is also what helps us keep us upright, which could contribute to back pain postoperatively. You have that large interbody footprint that really covers a lot of the vertebral body surface area, reduced chance of subsidence, increased chance of fusion. You can also address both foraminal stenosis by getting that increase in height. You can also get a little lordosis if you need it. And then, of course, you don't need an access surgeon, which is, I'd say, the biggest difference compared to an ALIF. So thanks, everyone, for listening to my talk. Thanks, everyone, for being here. Thanks, EANS, and, of course, to the CNS for providing this opportunity. For those of you who have not signed up yet, our CNS annual meeting occurs in about the fall every year. The late-breaking abstracts have just opened, so for those of you who didn't have time to get your abstracts in, now is a chance to get a late-breaking abstract in. QR code is right here. You can go ahead and shoot that or go to cns.org 2026. Go ahead and register, submit an abstract. We'd love to have you. We have a specific focus on our international colleagues, a special reception for you. As Amal mentioned, there are actually some, aside from the annual meeting, we do have different scholarships and things like that. And if you need any assistance applying for membership, we're always happy to help. So thank you.
Thank you, Dr. Chan. Yeah, for you guys that don't know, the CNS annual meeting is so much fun, and everyone is there. I mean, there's hundreds of people there, hundreds of neurosurgeons, residents from all over the U.S. and internationally. So it'll be great if you guys can make it. Just because of time, we're just gonna limit the questions to the Q&A section. I do want to say, if as a resident, if you haven't done a lateral approach, the other good thing with it is that for one level, on of course an experienced hand, you can do that case within an hour. I mean, it can be that quick. Our next talk is going to be by Dr. Helen Shih. Dr. Shih finished her neurosurgery residency at Oklahoma State University and is now a functional fellow. And she's actually finishing up her functional fellowship at Oregon Health and Science University. So she'll be talking today about new technologies in functional neurosurgery. Dr. Shih, please go ahead.
Hi, sorry, I'm in the OR right now about to start a case, so apologies for the weird background and the mask. Basically, I'm going to talk about new technologies in functional neurosurgery. So to start, I have no financial conflicts of interest. So basically, functional neurosurgery is a very exciting field where we're just full of new technology. And but in the early days, the very first new breaking technology in functional neurosurgery was the Horsley and Clark stereotactic device pictured below, which came out in 1908. This kind of revolutionized the field because up until then there was no stereotactic device. And then later on, in the 1980s, DBS, which was actually a European invention, also changed the field in 1980. And it was invented by Dr. Benavide in France. Sorry, my computer is acting up. So. Okay. Well, I have this nice image generated by AI. Are you seeing a zoomed in version or a normal
Yes,
version?
we are, unfortunately.
Okay.
Yeah.
Sorry, give me a sec. My computer keeps.
You can try and stop the share and try and share it again and see if they'll do it.
Okay. There. So I had AI generate this nice spectrum of functional neurosurgery devices, and I thought it did a pretty good job. So, as you know, there's constantly new devices coming out in the field. The newer, more established, the newer devices are on the left, and then the more established devices are on the right. And basically, historically, functional neurosurgery was characterized by ablative and lesion techniques, even going back to like the 1800s. But nowadays, we have we're focusing more on stimulation and reversible technologies. The exception not being functional ultrasound. And we're constantly developing new electrodes and arrays and wearable technologies for patients. And it's allowing us to treat diseases we could never treat before, like spinal cord injury, TBI, and other diseases. So it's a pretty exciting field in that sense. So we're going to kind of go over some of these technologies. In 15 minutes, I couldn't possibly cover everything, but I think the broad categories are stereotaxy, DBS, RNS, VNS, ultrasound, cell and gene therapies, brain and spine computer interfaces. Interesting enough, when I looked into, when I was preparing this talk, I realized that some of this is not available or approved in Europe, like some of the RNS device. So stereotaxy, this is basically the foundation of functional neurosurgery. The original Lexel G frame is still widely used today for a variety of cases, though I don't know if everybody uses the whole arc and rest of the frame. However, now what's becoming more popular is the robotic stereotaxy, the most popular one being ROSA, which is I think now considered a Zimmer Biomet device. And Medtronic also has the AutoGuide robot. These robots kind of came about in the early 2000s, and now most major academic institutions and a lot of private practice institutions in the US have them. And they're becoming more and more integrated with standard of care. And then there's more frameless technologies. The device shown on the right is called a smart frame, invented by a company called ClearPoint, and it's frameless in the sense that it's not a traditional frame like the Lexel frame. So more and more we're moving towards away from the original frame. The stereotaxy still remains a key part of functional neurosurgery. Next is DBS. I think everyone is familiar with deep brain stimulation. It's pretty well established as for its use in Parkinson's and essential tremor. However, more and more it's becoming used in epilepsy, pain, and OCD. For epilepsy, most people target ANT or CM. Pulvinar is also emerging as a new target. Pain, I think most of the papers I've seen for pain DBS actually published in Europe. But it's becoming more popular in the US as well. There's a variety of targets as well, although there's now one target.
Do you know how they get in access-wise through the?
Sorry.
Is it a perforator?
There's the perioctal aqueductal ray, and then there is also targets in the thalamus as well. For OCD and psycho neurosurgery, DBS is also becoming a new that people are exploring. Right now in the US, OCD is approved for the anterior limb of the internal capsule. So destroying it'll act as I'm not sure about Europe for OCD. And then device developments. So the original DBS electrode has basically evolved over the years, and now we have directional targeting. And coupled with directional targeting, Boston Scientific, for example, has AI programming. So now instead of a neurologist plugging in different entries in a patient's organisation session, they can have AI generate a shape using beta band and other electrophysiological markers that it thinks will best stimulate for the patient. And it's actually working remarkably well. I actually was talking to a patient in clinic the other day who said after programming AI program, her symptoms, she was getting nausea from the original programming session, got better, and she had total tremor control. And then Medtronic is known for its closed loop DBS, which basically uses like feedback to only stimulate when activated, which saves on battery and also allows for more finer control of tremors. And then rechargeable generators are now also more commonplace. So the generator change surgeries we've been having our PGY2s do will have to go down. Next is vagal nerve stimulation. This is actually a really interesting area. Originally, it was developed for epilepsy, but now more commonly it's being talked about for stroke rehabilitation. There's as well as use in autoimmune disease. So LivaNova is the company. It's been around since the 90s for vagal nerve stimulation for epilepsy. And they have two generators. More recently, they have a new generator called Sentiva 1000. It has more programming features such as AutoStim, which senses the patient's heart rate and will automatically stimulate the vagus nerve to try and stop or kind of ameliorate a seizure. And then you can do day or night programming because patients sometimes will seize less often at night, so you can decrease the amount of stimulation the patient is getting. This saves on the battery. In 2021, Vivistim came out, which is a new device used 6 months after stroke recovery to help with stroke rehabilitation. I think this is a device that's just been approved in the US and not in Europe right now, but there's a lot of excitement about it since this is the first device in a long time that's been, at least in the US, that's been approved for stroke recovery. And then this year, or last year in July, SetPoint that was approved. SetPoint is the third in the bottom right-hand corner. It's basically a pill-like device that kind of wraps around the vagus nerve and stimulates the vagus nerve for a couple minutes a day. And the goal of the SetPoint DBS is to moderate moderate rheumatoid arthritis and decrease DMARD use. I think in the initial clinical trial, they had 20 patients and 80% had reduction in the amount of DMARDs they were taking. The company SetPoint is also going to investigate this device for other and then RNS, so responsive neurostimulator. This is a device that's getting more and more popular in the US, especially since in 2025, their Nautilus trial came out and they got FDA approval for generalized epilepsy. And in the US, outside of this, there's currently nothing approved for generalized epilepsy. We have been using VNS for generalized epilepsy, but it's kind of an off-label use. It's just because those patients have nothing else. Originally approved for focal epilepsy, we have some patients a couple of years ago, in 2017. Basically, it's a device that continuously records ECOG and then also does closed-loop stimulation. It has a skull-mounted frame, as you can see in that picture, and this is to reduce the recording noise from a longer lead distance. And there's the option to do a depth electrode or a strip electrode, depending on where the patient's focus of focal location of the patient's seizures are. And then I think there's a lot, I think internationally, there's a lot of talk about the use of ultrasound. Ultrasound technology, ablations have been talked about, I think, since I was in college in like the early 2000s or something. But nowadays, it's finally become commercialized and developed into different products. So I'm focusing on HIFU and LOFU. HIFU is high intensity focused ultrasound, and LOFU is low intensity focused ultrasound. They have different uses, and they also have accomplished different goals. So for the high intensity focused ultrasound, basically it's better for targeting deeper locations, and also it is used ablate, like non-reversibly, technically. I say technically because sometimes the patient may recover from the original ablation and require other sessions. But the most common uses are in essential tremor and now Parkinson's. In the US, the PTT target was also approved last year, palatal-thalamic tract, for use in Parkinson's. Basically, for patients who are not good DBS candidates, this is a great modality. Unfortunately, it is non-reversible. So, it is sort of like if they get this, you can tell them that this should be one and done. However, on the flip side, it does make DBS planning easier should they fail. Should make DBS planning more difficult should they fail. LOFU is still investigational. It hasn't been approved for anything. In the tumor world, it's been evaluated for drug delivery and blood-brain barrier opening. However, it's currently also being used in epilepsy and psychosurgery research as well. However, that's all investigational. I think I saw a lot of data coming out of Taiwan about their current uses for it, especially with a device called NaviFus. For HIFU, the most well-known device is called, or I guess manufacturer is called Insightec. And then they also do LOFU as well. So on the left is the Insightec device, and on the right is NaviFus. All right. Cell and gene therapies are also big in functional neurosurgery right now. This is considered, not all the diseases are necessarily movement disorder diseases that are being treated this way. However, it's considered part of functional neurosurgery because it relies on stereotaxy heavily. So basically, it's currently it's the injection of stem cells or viral vectors into select locations in the brain for treatment of certain disease. This is done with some sort of stereotactic frame. I pictured the smart frame DBS system with a smart flow cannula manufactured by ClearPoint, which is a commonly used device for implantation of these stem cells in viral therapies. And on the right in that picture, you can see what it actually looks like in real time. This is an MRI GAD infused injection. This has to be done over several hours. You can only inject like a tiny microfluidic amount at a time. Then you have to wait like 2 minutes so that there's no back pressure so you can keep it in place. This is from the picture, it looks like this is like some sort of this is like a basal ganglia injection, probably for one of the Parkinson's trials. So this is a chart that I had to make actually that demonstrates some of the indications and major trials that are currently ongoing. Some of them are for diseases we've never been able to cure before, like Huntington's, Parkinson's disease. Blue Rock, I believe, is at the forefront with their cell therapy. And then in epilepsy, Neurona is at the forefront with their cell therapy. That's the one I have the most experience with. And then Alzheimer's and stroke, there's a lot of different companies with a lot of different therapies that are working on that. And not all of these are necessarily stereotactic. I believe the Alzheimer's ones, one of them is through an Ommaya and the other is intrathecal injection. Unicure, I think, is a British company, I believe, and they published results a year or two ago on their UK trial that showed halt in loss of caudate neurons. So, and it's coming to the US now for phase 1 studies soon, or phase 2 studies soon. And then I think the next big area in functional neurosurgery that everyone's very excited about is the brain-spine computer interfaces. I think this was talked about in the early 2000s as a theoretical concept, but now it's actually becoming reality. So currently, the main indications being investigated for is spinal cord injury. However, stroke, ALS, CP, MS, are not far behind. Right now, the focus is on patients with motor-based disease and to a certain degree speech compromised diseases. However, over time, I think that indication will spread as more understanding of the technology comes into place. Everyone, I think, has probably heard of Neuralink, Elon Musk's company, very well known. Right now, they're starting clinical trials. Their main indication right now is spinal cord injury as well as, I believe, locked-in syndrome. Those are the patient populations that I think the trial is enrolling for. Neurorestore, I believe, is a European company, and they have the ARC system that's pictured in the top right picture, which is a brain-spine computer interface system for patients with spinal cord injury. And then the bottom two, they are newer arrays. They're not necessarily ready for market and wearable technology yet. The Utah array is a famous array, and a lot of these brain interfaces are based on these types of arrays, electrode chips. And then the UCSD thin film electrode is also similar in line, except instead of having spikes that literally go into the patient's cortex, it is more of a fine film with thousands of channels that you overlay the patient's cortex. These can eventually be modulated into some sort of wearable device. So they're currently still testing. Utah array, I believe, is the only approved cortical recording array. Right. Well, thank you so much for your time. Any questions?
Thank you, Helen, for putting this together and for being able to do it while still having cases this morning. So I appreciate you. I think due to time restraints, we'll go to the next speaker.
All right. Well, thank you so much.
Thank you, Helen. All right, so our next speaker is Dr. Jessica Campos. Dr. Campos just finished neurosurgery residency at University of California, Irvine, and she'll be pursuing a fellowship in endovascular neurosurgery at University of South California. She'll be giving us a talk today about focused on vascular neurosurgery, and her talk is Beyond the Aneurysm, Rewiring the Future of Neurovascular Surgery. Dr. Campos.
Hi, everybody. Thank you so much. Hopefully you can hear me okay.
Yes.
Thank you. Wonderful. All right, so I'm going to go ahead and share my screen. Oh. Here we go. So hopefully you can feel. So here we go. We're just going to start into it. We have a lot to cover in a short amount of time. For those of you who don't know me, my disclosures are that I love open microsurgery. And I think the reason we all go into neurosurgery is that you find something that you love, you find a surgery you find beautiful, and you really enjoy taking care of those patients. And that's why we do what we do. And as you can see here, we're doing some microsurgical dissection, trying to find the aneurysm dome. And there you can see that bifurcation aneurysm in its totality. And then the microsurgical clip is going in to obliterate that completely. And so a lot of us go into this space to do exactly what's being seen here under the microscope. And unfortunately, as we age in neurosurgery, we realize that we need to do better. We need to do better for our patients. We need to do things more minimally invasive. And so with that, I'm going to do a very quick overview of the history of cerebral aneurysm treatment so that we can go into why the future of endovascular is so exciting and why you should also consider it as part of your armamentarium of becoming a dual trained surgeon. And why really I firmly believe that this is a huge part of neurosurgery and that we should all be a little bit more excited about it as well. So traditionally, cerebrovascular neurosurgery included hemorrhagic stroke, which includes aneurysms, arteriovenous malformations, and then also other disease processes related to steno-occlusive diseases, things like intracranial atherosclerotic disease and also moyamoya. Walter Dandy clipped the first aneurysm in 1937 with the aneurysm clips seen here in these photos. And then again, that case example that I described before, using either a terional or a modified orbital-zygomatic approach. And then we flash forward to, let's try to make this more minimally invasive. And the endovascular surgeons came into the picture, initially spearheaded by our neuroradiology colleagues and utilizing equipment that transformed the OR into an interventional suite. And it brings us to the first aneurysm that was coiled here in the world in California, at the University of California, Los Angeles, by Dr. Guglielmi in 1990-91. These were done with coils that were not initially made for the intracranial space. They were slightly large, bulky, and the catheters that they had at that time, again, not really made for the intracranial space. These were those GDC coils in the early 1990s, and then a coiling of a basilar tip aneurysm that now basilar apex aneurysms are almost universally coiled. So again, some of the limitations at that time were that there was a high rate of recurrence. We're talking almost as high as 33%, as described by Rem and al. In 2003, which brings us to the stent coil. So now we had increased coil compaction. We were able to get that coil density higher, but with that brought the need for a stent. And then with this, we put our patients on dual antiplatelet therapy. So you can see here some of the resolution that you can get with those wide neck or shallow aneurysms and then a tight coil pack. Then we flash forward to balloon coiling techniques, which there in Europe, Dr. Jacques Marais, Laurent Spell, they're in Paris. They've done a phenomenal job over the last few decades of really spearheading this space so that we can then flash forward to flow diversion. So flow diversion is utilizing a stent construct, but really you have increased right angle The revolution with photoversion is that you're reconstructing the entire vessel in totality. So you're having neoendothelial growth, you're having a new basically layer of blood vessel on top of the diseased portion so that your aneurysm can be obliterated over time. So it's truly healing the vessel from within versus microsurgical techniques. So the first ones were done there in Europe with you all in the 2000s with a metal surface coverage about 30 to 35%. This was really a feat in engineering, bringing it to the forefront of neurosurgery and neurointerventional surgery. So then this is by Dr. Calms and published in Stroke in 2007. You can really see here that layer of neoendothelialization has obliterated the aneurysm. So, really next generation treatment of aneurysms. We bring this to 2009, and then in 2011, a couple of years later, that's when it was brought to America. So you can see here the early indications for photoversion was for large and giant aneurysms of the internal carotid artery. And then this is effectively, you've hunted ophthalmic aneurysms to extinction in most parts of the world because of photoversion. And so you can add coils, you can use other adjunctive measures, but really you can get these beautiful results with aneurysm obliteration. Here you can see the stent construct here, that O sign. The arrows here are pointing to the photoverter with very good apposition there. And then you have contrast stasis seen in the late arterial phase. This is peri-procedural. And then you have 6-month follow-up where I don't even see the aneurysm. So I think, you have these wonderful technologies that brings us to multi-center and international trials. The POPS is very well renowned, and that's utilizing the pipeline. We have the 1-year outcomes now. We're more than 5 years out. This was more than a decade ago. And then we have other ones on the market as well. So Surpass there in Europe, you have the HP4 done by Phoenix, something that we don't have here in America. And then you have some other things that are coming down the pipeline. So you have Pulse Rider, which is available there in Europe. It brings us to the Web, which is an intrasaccular aneurysm occlusion device. And then you have not only do you have this sits in the aneurysm dome itself, and then you have some photoversion across the neck of the aneurysm. It's a little bit of both. So the surgeon's toolbox in this day and age is now coming from aneurysm clips and these fencing from Dr. Lawton's book. And then now we have these complex photoversion endovascular reconstructions of these disease vessels. And so really, there's an exciting class of ways to treat these aneurysms. And while microsurgical clipping remains an effective and safe option, I think when you're talking about how do you want your family members to be treated, we really are excited about how can we bring the next wave of tech to our patients in a safe and effective manner. Which brings us to how can we apply our new catheters, microsurgical techniques, and then also these the microcatheter techniques to our patients. So we're talking about chronic subdural hematomas, hydrocephalus and intracranial hypertension, CSF venous pathologies, even bringing it to neuro-oncology, so we can talk about breaking down the blood-brain barrier for our neuro-oncology colleagues, talking about headache and migraine applications, the brain-machine interface, which is a hot topic as Dr. Shi just discussed, and then even considering endovascular seizure monitoring. So for hydrocephalus, some of these are taken from the Ceravasc slides. This company spearheaded by actually South American colleagues with the idea to have transdural venous cisternoidal punctures into the arachnoid granulation to release CSF and then have that divert into the venous system. So Dr. Lilik down in Argentina and his colleagues have really spearheaded this so that we can have an endovascular shunt implant with the concept that you can deliver this small little device here, seen smaller than that of a thumb, into your inferior petrosal sinus. You can puncture into where the CSF granulations are and then divert CSF that way. I effectively patient these patients on a baby aspirin if that, where our target site again is that inferior petrosal sinus and that little CSF cisternal angle there, far away from the cavernous sinus. And so here you can see very quickly, we'll go, I can get this to play. Maybe not. But the hallmark of that is that here, this is the cisternal space. You have your device that fits there and a shunt, which is a one-way valve, so it's not titratable, and it can have CSF egress through that. This is going to be a great concept for our patients with subarachnoid hemorrhage who might outgrow their shunt once the subarachnoid hemorrhage is resolved, and we see that. And that initially spurred the necessity for the Certis shunt, which effectively has an off position at the setting of 8. Some of the early trial early data demonstrated was for normal pressure hydrocephalus, which showed an improvement of patients in their gait and as well as their early cognitive function. And then the last is that if you're a member of the STRIDE trial, that's looking at normal pressure hydrocephalus and its effectiveness in treating that. So we have a lot of patients here in America, and USC is actually a site, so I'm excited to start my fellowship and start enrolling those patients. Bringing us to chronic subdural hematoma, this is a hot topic. There was 3 international trials done, membrane embolized and the MAGIC MT done in China. This is from my own cases. This is an elderly male with worsening left upper extremity weakness, and you can see here this right-sided chronic subdural in the setting of his need for Eliquis for DVT. He also has pancreatic cancer, and in America, we don't really like to let patients die. So as you can see here, we wanted to have a minimally invasive approach for this. We did transradial access. You can have, here you have your angiogram revealing no concern for early anastomotic dangerous anastomoses. So you're looking at ethmoidal branches to make sure that you don't have an orbital blush from the ECA. You can see here on screen right, there's a lateral view of the ECA with none of those dangerous anastomoses. So the plan of attack here, you can see here your MMA tree, the parietal branch, frontal branch. At our shop, we like to do a hyperdilute glue, and then we coil off the stump of the MMA. And we'll be publishing these results soon, but what we see is that you can have cross-port injection. Let's see if I have it here. Across, you have artery-to-artery connections here over the sinus, not necessarily through the vein. And you can get really good penetration of your glue. You have a wonderful cast leading to these beautiful results here, which you can see the coil mass and construct here, and then a little semblance. There we go, zoomed in. And then you can see our hyperdilute glue cast here with ultimate resolution of his chronic subdural from a more than 1 centimeter now to barely noticeable. So I think what we're seeing in the future is, again, more advances in minimally invasive applications of neuroendovascular surgery for our patients. Again, just some of the trial that we've discussed when we talk about MMA. When we talk about venous fistulas, now we're discussing transvenous onyx embolization of the vein. So when you have these venous fistulas, you can do your digital subtraction myelogram under general anesthesia, put the peak to 0, and you try to see where the venous fistulas lie. And then when you do that, you can then go back later and do a transvenous onyx embolization for the azygous vein. The clinical applications are going to be for those patients with refractory headaches, spontaneous intracranial hypotension, and the advantage being that it's minimally invasive, shorter recovery, and we always do have open surgery for ligation of that fistula should it fail. For neuro-oncology, we're talking about breaking down the blood-brain barrier. Northwestern in Chicago is one of the sites for the Y90 utilization of CNS oncologic diseases using these chemotherapeutics. And then we're talking about intraarterial drug delivery. We've talked about decreasing the osmolar gap using mannitol or other microbubbles so that we can open that blood-brain barrier, and then give other things like pulse ultrasound so that we have better applications for our oncology surgeons. And then this would be utilized for GBM, lymphoma, brain mets. We're using now intraarterial chemotherapeutics for the retinoblastoma and pediatrics. So there's a lot of good applications there. And then now the floodgates are going to be open as we've noticed our patients with chronic subdurals, when we treat them with embolization, their headaches are starting to resolve. So some astute attendings noticed that and demonstrated that interventions for middle artery embolization for headaches and migraines are starting to have very promising results. There's now an international trial called the migraine study, which is being done with intraarterial administration of lidocaine. And if that works, we're going to consider embolizing those patients, and we're enrolling with that now. Looking at what the Synchron company is doing, as Dr. Sheehan mentioned, the Stentrode, which is associated with the COMMAND trial, that's looking at patients with severe paralysis, aiming to enable their controlled digital devices that are going to be hands-free. And that Stentrode is going to be placed in the superior sagittal sinus. So really exciting interventions and ways to bring science to our patients. We talk about endovascular seizure monitoring. Dr. Fujimoto et al. In 2024 described this version of PIG model, where he places the endovascular electrode within the transverse sinus. And you can see here down in the screen right, that's going to be normal subdural electrodes, which we're used to placing as neurosurgeons. And then you can see right here the endovascular EEG, and his study had demonstrated very high sensitivity that appeared equivalent to those of the subdural electrodes, or the subdural electrode grids. Again, this was done in a pig model, but then now we're looking towards where can we apply this in humans, and you see some of the sites across the country, and obviously the globe are looking at this too, so it's very exciting. So overall, endovascular neurosurgery is expanding beyond just common vascular diseases into various neurologic therapeutics. And with that, I'd like to say thank you to everybody. If you have any questions, I'm happy to take them.
Thank you very much. That was a really comprehensive and really on time talk. Thank you so much. It's really the endovascular route seems to be taking over the management, or trying to take over the management of a lot of versatile pathologies that were not even considered as endovascular targets beforehand. So this is really really important. Thank you so much. If there are any questions, please use the Q&A box. And we're going to move to the last session of the day. And thank you all for staying until now. I have the distinct pleasure to have two speakers that are very close to my heart, and I really, really admire both of them. I'm going to start with Aristotelis Kalivas, who was my senior trainee when I was starting, and then he left us to become an assistant professor in Canada at Toronto Western. And now he's back in Greece as an associate professor. And his field is oncology and skull base. But today he's going to talk to us about precision oncology surgery in the future of our specialty. And Aris, the floor is yours.
Thank you very much, Vangeli. Can you hear me and see my screen and my presentation well? Okay, thanks. So again, thanks for the invitation, the organizing committee, Evangelos, Sakiba, Imal. The title I was given is Precision Oncology Surgery for the Neurosurgeon of the Future. And I want to speak less about technology as an isolated topic and more about the judgment that will be required to use this technology well. I would like to address the neurosurgeon of the future directly, and your question will not simply be how much tumor can I remove, it will be what biology am I treating, what networks am I preserving, and what life am I protecting. Precision will not be aggressiveness, precision will be responsibility for you. The central thesis is simple. Precision oncology surgery is not simply surgery with more technology. It is a framework which is biology aware, network aware, corridor aware, and judgment driven. I'll try to separate the talk into two surgical languages. In gliomas, precision means understanding biology and interrogating networks. In skull-based surgery, precision means choosing the right corridor for the right biology, preserving neurovascular and endocrine function, and integrating surgery with adjuvant therapies. The anatomy differs, but the philosophy is the same. We'll use the phrase maximal safe resection, but maximal and safe are both terms that are changing. Maximal now can include enhancing tumor, flare disease, or supramarginal strategies. Safe can no longer mean moving and speaking. What does maximal resection actually mean? Should we go for the flare in high-grade gliomas? In this large cohort, 761 patients, resection of contrast-enhancing disease, improved survival, and in younger patients, additional flare resection was associated with further benefit regardless of the molecular subtype, as you can see in the Kaplan-Meier curves. The RANO-resect group pushed this further in more than 1,000 IDH wild-type patients. The best survival was seen when surgeons removed enhancing tumor plus at least 60% of the flare abnormality, leaving less than 5 cubic centimeters behind. Median survival increased from about 20 to 29 months. In low-grade gliomas, the same direction is even clearer. Resection beyond the flare abnormality, what we call supratotal resection, was associated with better survival than gross total or subtotal resection. The benefit was strongest in astrocytomas. In oligos, the signal was less definitive, but the trend still favored more extensive resection when it can be done safely. So our goals have clearly evolved, right? We have moved from watch and wait or biopsy to subtotal resection towards gross total, and now in selected cases, supratotal resection. But the boundary is not the ambition of the surgeon. The boundary is function. And here precision is not maximalism. Precision is our strategy. This brings us to the other half of the equation. What is safe? In this GBM study, patients with new postoperative deficits had worse survival, 9.2 months versus 14.7 months. So even if we remove more tumor, the benefit is lost if we injure function. This is the figure from the initial paper that defined the Spetzler-Martin grades and defines eloquent areas only as M1, S1, Broca's, Wernicke, and primary visual cortex. And of course, the field has changed completely since then, and patients live far beyond these functions. Motor eloquence must include cognition, conation, emotion, behavior, and the ability to return to work and to identity. So the endpoint is not the neurological exam alone, it is meaningful life after surgery. And this is where the concept of hodotopy, coming from the Greek words for road, odos, and place, topos, becomes important. Function is not only a place, it is places connected through pathways, and white matter matters. The future glioma surgeon must operate inside a connectome, not on a flat map of isolated cortical spots. Modern imaging is extraordinary, and future imaging will be more extraordinary. Structural MRI, perfusion, spectroscopy, PET, fMRI, tractography, AI, and augmented reality helps us build a preoperative hypothesis, and we can take some of this information into the operating room with us. They tell us where the tumor is, what biology it may have, and where risk may be. But powerful here does not mean definitive. Going into further detail in fMRI and DTI and risk estimation of a neurological deficit, recent large-scale studies like this one from Paschini and colleagues show that language reorganization in glioma patients is not just theoretical, it is frequent, measurable, and clinically relevant. This reorganization often follows a pattern, first within the tumor, then around the tumor, and finally towards the opposite hemisphere. And task-based fMRI can help us visualize this plasticity. It can show shifts in language dominance depending on tumor location and tumor biology. For example, in left high-grade gliomas, right-sided Broca or Wernicke activation may reflect MGMT methylation, so more time for reorganization. So fMRI is useful not only for planning, but also for counseling. But can fMRI replace intraoperative language mapping? Probably not. Meta-analysis show variable sensitivity and specificity. So fMRI is excellent for showing patterns of activation and generating a surgical hypothesis, but is not reliable enough to define resection limits in eloquent areas. Motor fMRI performs better, especially for hand mapping. This means it is very useful for the planning and the craniotomy and dissipating the risk. But even for motor mapping, fMRI can overestimate the functional boundaries. So again, it can guide the operation, but direct electrical stimulation and intraoperative mapping defines the true intraoperative limit. The same principle applies to tractography. Can tractography be considered ground truth for white matter? The answer is no. It is a model-based reconstruction, not a direct anatomical or functional map. Even advanced methods like Hardy or DSI improve accuracy, but they still depend on assumptions, algorithms, and image quality. And let's say we fix all this for the neurosurgeon of the future, and we have structurally something that is almost the same as the truth. There's a bigger issue. Tractography does not represent function. Dufault's concept of the minimal common brain reminds us that some Deep subcortical structures have very limited plasticity. The superficial fan of a tract may sometimes be compensated and can be resected, but the deep converging stem often cannot. That is why we need subcortical stimulation, and tractography helps us navigate. But intraoperative mapping tells us where function truly is. So this is probably the most important message in the glioma section. fMRI shows activation, tractography shows an estimated model of white matter, navigation shows preoperative geometry, and fluorescence shows a tumor-related signal, but direct stimulation tells us what is essential for that specific patient at that moment. Imaging creates hypotheses again, but intraoperative mapping tests them. Vorasidenib is an important example of the new era in the INDIGO trial. It improved progression-free survival and delayed the time to next intervention in IDH mutant grade 2 glioma. But this does not mean changing the surgical strategy or, of course, the end of surgery. It means a more sophisticated sequencing question: when to operate, when to use drug therapy, and how to preserve cognition across a disease trajectory that may last many years. And the importance here is that you can delay radiation therapy. Glioblastoma teaches us humility. We understand more than ever about molecular subtypes, single cell states, a microenvironment, and tumor neuron interactions. But outcomes remain difficult because the tumor is heterogeneous, protected by delivery barriers, and evolves under treatment. And the future, for that reason, will probably not be one magic bullet. It will be combinational, adaptive, and biologically monitored. Focus ultrasound may become a new type of neurosurgical intervention in oncology, not a craniotomy, not radiation, but a specially targeted biological gateway. It can transiently open the blood-brain barrier, facilitate drug delivery, potentially support liquid biopsy, and modulate the tumor microenvironment. It is futuristic, but it's no longer, of course, science fiction. We have data and we have trials, and we're looking forward to further progress there. Let me now transition to skull-based oncology. In gliomas, we ask what function cannot be crossed. In skull-based surgery, we ask what corridor creates the least morbidity. In both fields, precision is knowing that boundary. And the history of skull-based surgery was built on exposure. The future will probably be on selection and strategy. Patients want cure or control, but they want also preserve cranial nerves, vessels, cosmesis, endocrine function, and a fast return to life. They do not ask us for a beautiful approach, they ask us for a good outcome. And skull-based surgery always has exciting new trends, and today transorbital endoscopy is one of them. But the future skull-based surgeons should not be only, let's say, open or only endonasal or only transorbital. They should be a corridor strategist. The approach must follow the anatomy, pathology, extension, reconstruction needs, and morbidity profile, and for sure not fashion. Robotics may help skull-based surgery by restoring dexterity inside narrow corridors, but current limitations include robot size, cost, lack of haptics, good haptics, limited neurosurgical instruments, and especially the challenge of drilling. The right question is not robot or no robot. It is which task should be augmented. And I am sure we will do much better here in the years to come. In skull-based oncology, precision may mean knowing when not to resect more and then what. We are trying to improve radiation strategies, and we made some good progress with radiosurgery and more recently with proton therapy. And radiation oncologists are now looking into carbon ion radiotherapy and other particle therapies, which is especially relevant near the optic pathway, brainstem, cranial nerves, and for histologies such as chordomas and chondrosarcomas. With the aim of surgery becoming one step in a planned surgery radiation exposure if needed. Artificial intelligence, augmented reality will improve diagnosis, segmentation, prognostication, visualization, simulation, and workflow, no doubt. But all these, for now, are amplifiers. They are not arbiters. The augmented surgeon still needs an unaugmented virtue, which is judgment. Pituitary surgery is a perfect example of the future patient pathway. A future for pituitary surgery will not only be what happens from sphenoidotomy to closure, and will include earlier diagnosis, and radiomics will play a huge role there, I think. Molecular imaging, simulation, augmented reality, advanced optics, smart instruments, and post-operative prediction of remission, recurrence, and complications. MRI remains the foundation of pituitary imaging, but in small, equivocal, persistent, or recurrent pitnets, anatomy may not be enough. Molecular imaging, particularly PET MRI and amino acid PET, may help us localize biology, metabolism, receptor expression, and amino acid transport. So the future question is not only where the lesion is anatomically, but where is the biological signal for that. So in conclusion, the neurosurgeon of the future should not be concerned that they will be replaced by technology, as Elon Musk says, but they may be replaced by another neurosurgeon who combines technology, biology, anatomy, mapping, and judgment better. And for the end, I would like to take this opportunity and invite you to the 7 glioma surgery course taking place in Athens, Greece on October 23rd and 24th. And you can scan the QR code anytime for info or registration. This is not a standard conference, but an intensive hands-on workshop focused on modern glioma surgery, awake and asleep brain mapping paradigms, maximal safe resection, and network-based surgical anatomy. 20 spots for 20 participants. We will have focused lectures, interactive discussions, cadaveric brain mapping sessions, and white matter dissection. And we are honored to welcome an outstanding international faculty, including keynote lecturers Lorenzo Bello, Mitchell Berger, and our own president of EANS, Francesco Sala. And this is the state-of-the-art brand new NeuroLab venue that the course will take place. And thank you very much for your attention.
Thank you very
Happy
much.
to take any question.
Thank you very much. Are there any questions from the panel for Aristotelis? Cannot also see any question in the Q&A. Please put any questions in the Q&A, and we can either respond there, or I can send them to Prof. Kalivas later. And for the last session of the meeting, we have Mr. Carter, Mr. Michael Carter, who is one of the gurus of epilepsy surgery worldwide. And I'm really happy to be working very close with him, and having the opportunity to share, into his experience. He's running one of the busiest epilepsy services in the country, and he's doing some amazing things. And he's the perfect person to kind of tell us what he feels and what he thinks the future of that part of neurosurgery will be. I think you are muted, Mr. Carter. Can we please unmute him?
Yeah, there you go. How about that?
Yeah, perfect.
That better?
Perfect. Thank you.
Okay. Well, Evangelos and committee, thank you so much. I really don't deserve any of that talk up you just given me, but it has been a great pleasure to be part of your ongoing surgical education, and just to set the scene really about epilepsy and epilepsy surgery. I mean, bear in mind that there's somewhere in the region of 70 million people with epilepsy on this planet at the moment, and 70% of those live in low or below average income countries. So the burden worldwide is absolutely enormous, and about 30% of them probably don't respond to medications if they can get them. So epilepsy surgery is not a minor thing. It potentially has applications which are literally worldwide. and ongoing. Okay. Some problems advancing my screen here. Oh, there we go. Yeah, absolutely. So just to say that epilepsy and the association between epilepsy and structural changes, mainly by injury, it has been known about for a very long time. The ancient Sumerians wrote about it 8,500 years ago. The ancient Persians reported it a lot after war and injuries. And of course, running onto the 20th century in Bristol, Gray Walter made the association between lesional changes and changes in the EEG. This was advanced upon by Wilder Penfield, of course, who gave us the homunculus and localization during awake craniotomy for epilepsy. So he was very much one of the leaders. And I think it's a good idea to think about where you've come from, because it does kind of indicate to an extent where you may be going. And where we're going, I think, with this is the stars. This is Commander Tim Peake on the International Space Station. And that thing he's got in his right hand there is a TMD Mark II intracranial pressure wave analyzer, which is interesting because it's currently in my garage, that particular one, because we helped make it in Southampton. But he also grew neuronal stem cells in space. That was his thing, and it's really fascinating. So that's where we are going. So neurosurgery, what is the role of neurosurgery in epilepsy? Well, neurosurgeons are manipulators of tissue and lesions that generally they can see, that being the nature of a lot of what we do in neurosurgery. And of course, in the world of epilepsy, that may mean ectomizing a lesion, for example, a tumor causing epilepsy, or atomizing something, actually dividing fiber tracts and disconnecting areas of brain that are thought to be involved in the generation or sustenance of seizures. And that's a functional hemispherotomy there. And these are still the mainstays of what we do in epilepsy surgery at the present time, but this is changing. One of the things that the future neurosurgeon is going to have to be is a technologist, because one of the problems we have in neurosurgery, of course, for epilepsy is that some of the lesions you can see, like a tumor or a scar, but some of them, of course, you can't. They are lesions, of course, they're probably electrical regions, but they have to be identified by means other than straightforward imaging. And I just want to talk a little bit about some of the things that are coming down the pipeline that I'm really quite excited about, one of which is source localization using high density EEG. And this is a beautiful conglomeration of EEG technology and also AI algorithms as well that allow us to look at things in completely different ways, manipulate data sets in order to actually give anatomical localization of what is essentially electrical activity. It's still relatively in its infancy, this, but I think it's incredibly useful and may at some point even provide an alternative to some functional investigations that we currently use as part of our mainstream sort of armamentarium, such as PET and SPECT scanning. So source localization, high density EEG. This is something that's worth looking up if you're interested in epilepsy surgery. Okay. Another way that's been really very interesting in terms of trying to identify the electrical lesions associated with the onset of seizures being magnetoencephalography. It's not a new technology, but it's been hampered very much in the past by the fact that it's incredibly bulky, technologically complex and difficult to do. But there's new technology on its way, optical pumped magnetometry, or OPM-MEG, which allows this technology to be used in far more non-technological settings, shall we say, and in a way that doesn't require absolute stillness. So it's something that's fantastically good for children. So this is a technology that you'll all be familiar with. It looks for dipole changes associated with seizure onsets, but OPM-MEG is something that's very important, and I think that we'll be using this a lot in epilepsy surgery in the years to come. Okay. The other way, turning lesions that you can't see into lesions that you can see, turning the unseen into the seen. Well, again, artificial intelligence, the ability to take on enormous data sets is something that's been increasingly looked at in the interpretation of MRI and other imaging at the moment. And the MELD project, which has sought to actually analyze hundreds and hundreds and hundreds, in fact, thousands of MRI scans for the presence of changes, subtle changes in cortical architecture indicative of cortical dysplasias, which, as we know, are one of the commonest causes of seizures in children. This is a very interesting project, actually. It's something that hasn't yet got to the stage of being clinically licensed in the United Kingdom or in Europe, but in fact, I think is going to be at some point soon. And I think it's a very interesting technology. It's largely being run out of the UK at the present time, but it is moving out across the world. And again, I think this is something that's worth following, because I think we'll be using it. And of course, we have the wonderful advances day by day, it seems, actually, in image guidance at the moment and neuronavigation, which may be combined with all these other modalities in order to create a lesion that we can see resect or possibly disconnect. So that's something that you need to be on top of. Neurosurgeon of the future, the epilepsy neurosurgeon of the future definitely needs to be a technologist and needs to be able to follow these things and take them on. The neurosurgeon of the future, in this vein, also needs to be a stereotactic neurosurgeon and a roboticist. The two are combined together, of course, in the wonderful technology that we now have, stereotactic EEG implantation, which allows us to record from the living brain by the implantation of, what have I done? Oh, my screen's slightly frozen. Hang on a minute. Oh, there we go. Well, the precision implantation of depth electrodes into the brain, which of course has taken things to a new level in terms of diagnosing epilepsy, because it means that we can interrogate volumes of brain and triangulate between individual recordings in order to work out where seizures are onsetting, but more importantly, also where they're going to. And this is a great technology. It's very powerful. We probably use it in about a quarter of our receptive cases at the moment, if not a third. And it enables us to do a certain amount of cortical mapping as well as actually little lesional identification, which is very important if you're trying to avoid doing harm. The robots are coming. You're going to have to get used to them. It's worthwhile making friends with them now before the robot overlords overtake us. We should overtake them. And that's what a stereotactic implant looks like. If you show that to patients, they usually get quite upset, but it's actually very well tolerated in most cases. And this is what you get. You get fantastic localization. And, you know, once you have a team that's doing this kind of implantation regularly, it really does change your practice a lot. And it also informs a great deal about our ability to access really quite difficult to get to places like the insula and certain areas of the motor cortex, which hitherto have been regarded a little bit as being somewhat verboten. Okay, going to move again. Okay, so the other thing about the robot, of course, is it means you can put other things other than the electrodes into the brain very deeply and very safely. The neurosurgeon of the future, epilepsy neurosurgeon of the future, I think is going to be a laser surgeon as well. We now have the technology of LIT, interstitial thermoablative therapy, laser fibers deployed using stereotactic imaging and algorithms can be advanced deep into structures deep in the brain, avoiding disruption of other eloquent areas and structures. And the current systems allow us to actually undertake real-time laser ablation of tissues in the MRI scanner so that we can plan, destroy and avoid important areas all in one go. And for certain things in epilepsy surgery, for example, hypothalamic hamartomas, and this is one of our cases here, it's proven to be a game changer because the alternative of this kind of ablation was an open operation, probably going through the temporal stem, which carries with it about a 25% chance of a serious a complication and probably would put somebody in hospital for upwards of 2 weeks. The patient who underwent this surgery had no complications and went home after 2 days and remained seizure-free. So this is very important. It's not only for destroying lesions, you can deploy lasers also for undertaking major disconnections here, for example, the corpus callosum, and you can also do whole hemispherotomies using them as well. So this, I think, will be something that will be increasingly used in the future. But the robot, of course, has been absolutely monumental in sort of like pushing us forward in the world of functional neurosurgery as well. And I think that the epilepsy surgeon of the future will most definitely be a functional neurosurgeon. Increasingly now we're beginning to consider the possibilities of deep brain stimulation in the treatment of medically intractable epilepsies, particularly the generalized epilepsies, which often don't have an obvious surgical remedy otherwise. And certainly looking at the anterior thalamic nuclei is something that's becoming increasingly of interest in the world of epilepsy. I would just point you to a couple of studies going on here, one of which is the Brain STEP study, which we very much hope is going to be launched in the UK if we can get the funding for it sometime in the next year or so, which actually looks at anterior thalamic stimulation in patients who failed VNS therapy. So this, I think, is going to be a very, very interesting study. It's a blinded crossover study. It should be really quite informative, and we're very, very hopeful for it. This is run by my colleague, Will Singleton, out of Bristol. And of course, there's another trial that's actually active at the moment, the Cadet trial, which is looking at the use of brain stimulation from the PicoStim, which is a responsive stimulatory device. This is run out of Great Ormond Street. We're going to be part of the trial too. in the next few months, and it's looking at the treatment of patients who've been diagnosed with Lennox-Gastaut syndrome. So two very big trials, I think, that will pave the way for the next sort of series of investigations, I think, in or the ongoing interest in functional neurosurgery for epilepsy. I think that the neurosurgeon of the future is definitely going to have to be a neuroscientist with some kind of an understanding of neural networks, because neural networks, of course, are what sustain epilepsy. Epilepsy is not just necessarily a lesional thing. It's all about a dynamic imbalance between excitatory and suppressive forces throughout the brain. So we're beginning to understand a lot more now about where these nodes are, and it may be a node rather than a lesion that is a target for an intervention of some sort. And this is something that's very much being researched at the moment using large data sets from multiple investigations. This network analysis has been undertaken at the moment in Bristol with my colleague Olivier Sweeters, who's one of our trainees and one of Evangelos's colleagues and workmates. And really, this is a lovely piece of work. He's developing a computational model which looks to actually undertake virtual resections to tell us what the outcomes of our investigations may be. So those of you who know Ollie, that's what he's doing. Okay. And of course, there are other ways of manipulating these networks as well. You don't necessarily have to excise them or stimulate them. You can stimulate them dynamically, potentially. This is a very interesting area of work that I'm particularly into, which looks at optical manipulations in the brain. We know, for example, that neurons produce photons. They produce entangled biphoton pairs. Now, why they do that, nobody really knows, but it obviously takes a lot of energy to do this, and they do it. They produce about 900 a minute, roughly, which is actually quite a lot. And you can detect this by optical monitors within the brain. They're also always of a wavelength, which is totally internally reflected down the microtubular system of that neuron. So why are they doing this? We don't really know. But it implies that there are some associations between neuronal function and optical manipulations within neurons. And this is something I'm very interested in looking at. Other people have been thinking the same sort of thing. And we know that we can manipulate the oscillating systems within the central nervous system externally without necessarily having to actually do anything to the brain itself. And in fact, you can actually suppress seizure activities with LEDs applied via special glasses externally. It has a certain effect upon certain wavelengths, and certain kinds of optically active epilepsy can actually be suppressed using external light. And in fact, George Ibrahim and his group in Toronto have been using white noise in a similar sort of way. So it's very interesting. We have to be aware of all these possibilities. In Bristol for the past few years, we've been resecting tissue from the brain, and some of it goes off to the lab for histology for the epilepsy cases, but a lot of it didn't. And so we've actually now got a project where we're keeping this tissue and we're sectioning it and we're attempting to grow it in culture so that we can actually analyze the cells themselves. And there you go, that's a pyramidal cell from hippocampus that we actually grew, which is quite something. I'm very proud of that one. It's been inflated there with contrast. Not easy to do, and the team have become very good at doing it. We've got a kind of rescue system for picking up the tissue and oxygenating it on the way to the lab. But the interesting thing about this is we can keep micro slices of tissue alive in the lab for long periods of time now, and we can even grow them on chips. So if you're interested in actually looking at the way in which neural networks form, this is a great way of doing it and how they work, because you're not inferring it from the output on EEG. You're actually looking at it in real time. And this is something I think that will inform our understanding of networks and the ways in which we may actually be able to manipulate them greatly. And the other thing we're doing is extracting hippocampal stem cells from the mesial temporal lobe resection specimens and growing them into spheroids. There you go. Now that's the concept of organoids and spheroids is a whole different concept. It will take me 5 days to tell you about this in any kind of detail, but suffice it to say, a living spheroid of hippocampal stem cells will turn into hippocampal neurons, and if you negotiate it in the right way, will become functional allocortex. And the reason this is interesting is because it opens the gateway to the holy grail of neurotransplantation and CNS repair. And this is what I think we are all kind of like really interested in. And I don't know if any of you guys follow neurosurgery from North America in the popular press, but this is a picture of a seal. That seal on your screen right, top right, is Grown-Up, and he's a Pacific sea lion who actually was managed, can you believe it, in San Francisco Children's Hospital. And the reason for that is and if you don't know, is that the changes in the ocean temperatures at the moment are facilitating the growth of red algae rather than green algae as the basis of the food chains. And red algae, unfortunately, produce a certain toxic called domaoic acid, which selectively poisons GABAergic neurons and will knock out your hippocampus if you eat enough food containing it. And that's what's been happening to the seals of North Pacific and also in the North Atlantic as well. And seals, and you wouldn't know this unless you're a bit of a nerd about it, have been coming ashore, biting people, which they don't normally do, getting stranded and developing epilepsy, which is often temporal lobe epilepsy because they've knocked out one or both of their hippocampi. And in fact, Grown Up was an inpatient at one of the North Pacific, Californian marine mammal rescue centers, and he underwent a procedure which they've been kind of researching in San Francisco for quite a while, where he actually underwent a transplant into his mesial temporal lobe of embryonic porcine median eminent cells, which then grew into and reconstituted his mesial hippocampus and stopped his seizures. So it's an interesting thing. Obviously, it's in a seal, and there's a lot of stuff to be done there, but it's almost the conceptual side of this wonder that gets me, because if you can do it in a seal, you can do it in a person, okay? And at the bottom down there, that's Bananarama. Bananarama is a 6-year-old harbor seal that's currently living in the seal sanctuary in Wiek in the western part of England, a place called Cornwall, which is very, very beautiful. Similarly, temporal lobe epilepsy, terrible seizures, and we're just wondering at what point we may be asked to get involved in that. You also need to be a bit of a technologist and a bit of an entrepreneur, really. Here we are. That's my epilepsy surgery nurse, Michelle, there, and she's holding that little briefing she's got in her hand. There's a little tiny ceramic electrode and Wi-Fi receiver, which is actually an implantable, externally powered and modulated vagal nerve stimulator. And this is fascinating stuff. We've been working this up with the vet school locally, our great collaborators, and also colleagues at a little startup in California. And this is incredible because it's a procedure for VNS, which can be very effective in palliating seizures, if not curing them under some circumstances, but it's powered externally, and it's powered by rechargeable batteries, solar rechargeable batteries, and the whole thing costs about $400. So, you know, if you consider that the VNS units that we mainly implant in Europe cost the best part of about $20,000 or $30,000 to implant, and they need to be replaced from time to time, this is a big way forward. Obviously, this is just in dogs at the moment. It works fantastically well for dogs. That's me trying it. Hopefully, I don't have seizures yet, but you know, I think it is going to be usable for people. And we're very excited to be moving forward with that. What else? Well, the epilepsy surgeon of the future is going to need to be a damn good surgeon. That's the basic thing. You can't get away with it. Okay, you can be, you know, you can be great at stereotaxy. You can know everything about research, and you can know networks and AI algorithms till cows come home. But at the end of the day, you're going to be doing some pretty out there things like hemispherotomies, pretty in there things like operating on the insula, right? So you need to know your anatomy. You know, you need to have spent time banging the books. You need to have gone to theater a lot. You need to be in the lab looking at dissections. Okay, there's no getting away from it. You're a surgeon. This is what you do. Okay. You also need to have some consideration for the rest of the brain. You know, in epilepsy particularly, the physiology is very important. The whole thing is dysregulated. It doesn't just affect one area, it affects the whole of the brain. It affects the autoregulation, it affects the metabolism, and you have to be aware of that and constantly remind yourself of it when you're considering your treatments and considering the interventions you might want to make. Okay. Very important part of epilepsy surgery, of course, is destroying or removing the bit of brain that's causing seizures, but equally you want to protect the bits of brain that aren't causing seizures or may be functionally very important. So functional MRI is a wonderfully fast-moving technology at the moment. We use it for motor localization, speech localization, and increasingly memory localization into the hypothalami. So that's a fantastic thing. And we make a great deal of use these days of tractography as well, because they will often demonstrate to you tractograms where you can and where you can't go surgically. Okay. Surgeon of the future also needs to be an endoscopist, because there's a general move towards minimal invasive therapy, and an awful lot of the operations that we do as big open events may well be replaced by ones or augmented by procedures that involve endoscopy as well. And the robot can be deployed to hold the endoscope. That's the other thing I will say. So that's another thing you need to be good at. Now, the epilepsy surgeon of the future definitely needs to be a team player. That's the pediatric epilepsy surgery team at Bristol. Most of us have worked together for more than 15 years now. And, you know, it's a flat hierarchy. Everybody brings something new to the table because there's so much in it. It's so much more than just the surgery. There's psychology, there's nursing, psychiatry, neurophysiology, neurology, the clinical assessment, and the psychological, psychosocial outcomes are as important as any of the other investigations we do. And that's what a team does, okay? You need to be collaborative as well, sometimes with human clinicians, sometimes with clinicians that don't work in human world. So that's my good friend Tom Harcourt Brown, who's a veterinary neurosurgeon at the vet school in Bristol, and that's our first VNS canine patient, Jago, who did very well actually, became seizure free on his VNS. Okay. The other thing that's important is that those of us who regularly go into the central nervous system, implant things into it, okay, are a vital resource for researching in neurosciences generally, because nobody else can do it, okay? And I think we should take part in this. Micro single electrode recordings and microcellular recordings, for example, in memory function is something that we've been doing in Bristol, and that's something that I think that everybody should be aware of and want to contribute to. There we go. The other thing is the epilepsy surgery of the future is very likely to be a pediatric neurosurgeon as well. You know, bear in mind that the vast majority of epilepsy starts in childhood, and we find in our own epilepsy surgery program. When I was working in the adult program, I found that about 90% of the patients we saw in the adult program would have met criteria for admission under the epilepsy surgery evaluation program at the ages of 5 or 10. So the vast majority of this kind of epilepsy starts early, and that's where you need to get to it, because you make the biggest outcomes. And the earlier you operate, the better they do. And you can preserve that most important thing, developmental capacity for them. Okay. Neurosurgeon of the future is a teacher and an educator. Okay. Everybody needs to know about this. There aren't enough of us. There need to be more of us. Okay. Needs to be a mentor and a friend. And that's the end of term dinner, Evangelos. You probably remember that a couple of years back. To those coming, you know, because we are nothing if not supporters. Well, you know, we haven't achieved anything unless we bring people on behind us. And I think the other thing that we all need to be really is we need to be moral philosophers and consummate humanitarians, because, you know, lasers, growing cells in culture, all this kind of stuff is absolutely wonderful, and I can't get enough of it. But I'm acutely aware in my own practice that what I do is available to less than 0.001% of the world's pediatric population. And that is something that we should all consider and should all inform what we do and make us want to move forward as a species, you know? And the only other thing to say, and I think I might not be able to show you the slide, is, no, go back. There you go. I think that, you know, neurosurgery, epilepsy surgery is a wonderful thing to do. And I think that it'll be a very major part of neurosciences moving forward. But, you know, it is surgery. And God does have a sense of humor. So I would encourage anybody involved in this, and I would definitely encourage you to do it, needs to encourage them themselves, cultivate a sense of optimism and a very strong sense of humor. And that's all I have to say on the subject. Thank you.
Thank you so much. That was a really thought-provoking talk, especially the dog pictures.
I thought everyone loves that. I don't know why.
As a Labrador parent myself, that was very close to heart.
Labrador parent. I know where you're coming from. It's good.
Yeah. Does anyone have any questions? There are no questions on the Q&A, but anyone from the panel? I can ask a quick question.
Sure.
Mr. Carter, you were talking about hypothalamic tumors. What percentage of them are being done open? Are there any that are now being done open, or?
Yes, I think there are. I mean, I think
in the pediatric population,
things are. You mean in hypothalamic hamartomas? In the moment in the UK, we're not really deploying laser therapy for tumors unless they're specifically epilepsy-causing tumors, just because of the expense and the funding of the whole thing. Really, I mean, as yet that hasn't been worked out. But you know, we started with laser about a year ago, and I don't think we've not even considered using any other means other than laser since then, because the advantages are just so enormous. You know, any kind of major approach to the third ventricle is not a bunch of laughs, that's for sure. Least of all for the patient, and it's very expensive, puts them in hospital for a long time, very high morbidity as well. You know, carefully curated, and they do have to be carefully curated, because you can still have complications with lasers, but you know, you have the great advantage of trajectory planning using very high quality software, and you have the great advantage also of actually real-time monitoring as you do it, so you can stop. You know, you put your little stop targets all around the areas you want to preserve, and you don't destroy those. There are several. There are two major companies at the moment that make this. There's the Medtronic system, which is Visualase, and there's another one as well from North America that isn't available outside North America. I can't remember the name of it now, but that's slightly more directional than the Visualase, and it's slightly more automated. But I think it's changed hypothalamic seizure surgery completely in this nation. I don't think anybody will be doing open surgery for it now.
Brilliant. Thank you very much. Does anyone else have any questions? If not, I think we should bring this to a close. I want to thank all my colleagues, Evangelos, Mary, Milan, and then obviously ML and the CNS group for joining us for June this year and doing a brilliant job. And to all our speakers and obviously all the attendees, we will send out a poll. If everyone could respond to that, that would be great. And we hope to see you at more EANS YNC events. Please join the network and keep in touch. And if any of you have any questions, please get in touch with us. Our contact details are on our website, or you can contact us through the office. And if you have any specific questions for any of the speakers that were here today, I'm sure we can forward those on to them if you let us know. Okay, I think with that, I think we'll let everyone go and enjoy.
I think
what's left.
the last people who will need to join are the EANS office.
Oh yes, of course.
Martina and Valentini, who have been in the background making sure that all of that is happening. And I know it's burning where they are now, so we do owe them a big bottle of water, not alcohol, bottle of water when we
I'll get the alcohol. Ignore forget it. Yes, spritz. But yes, thank you very much for helping us make this happen.
Thank you all.
Okay,
Thank
take
you
care.
all. Enjoy the weekend.
Thanks a lot. Bye bye.
Thank you.
Thank you. Bye bye.